Good morning to everyone.
Good morning.
Good morning. I hope all of you had a good, pleasant journey just now. Right, traffic seems to be quite low, right? So that's great. So Dr. Bala walked in a bit late. However, it's quite a time that we can start away with usual start what we call icebreaker, right? Icebreaker. I'm not going to explain what is icebreaker, but it's a mode of introduction. Okay, mode of introduction, and liberate you from the ice kind of feeling that you have inside you. Okay, that you restrain yourself to move freely. Okay, so I'm Dr. Kiran, right, from Polyclinic MK Telogong, and we are going to have some time to know each other. Okay, would you mind introducing yourself, doctor? You can sit and talk. Be at ease. Your name? So we are starting with Dr. Ashini. Anyway, give a big hand for her. Hey, that's good. Right.
I'm Harshini. I'm soon to be working in HSA.
All right.
Next month.
So she is a doctor who's going to join HSA soon. Right. Great. That's fine. Anyway, doctor, would you like to add upon any other cases, or probably some cases that you have seen in the past? Some injuries in your practice or during your student time. Have you seen any cases? Can you elaborate on them?
I've seen a case on pleural effusion.
All right. Okay. Fantastic. So pleural effusion, very important case, right? Pulmonary pleural effusion. I think you would have done the tapping, right?
I've seen it.
Seen it, huh? Okay, good. Any injuries and surgical intervention?
I have assisted a case on fibroadenoma of the breast on a 17-year-old.
Excellent. That means you would have done some kind of assisting the doctor, the surgeon there, to operate on the patient, right? Excellent. Give a big hand. Thank you. Doctor, can you please introduce yourself?
So, good morning, everyone.
Good morning. Good morning.
So, I'm Dr. Bhavani from Polyclinic MK Panamaran.
Right.
So, I started my housemanship in Hospital Sungai Buloh and gradually continued my MO-ship in Hospital Tengku Afwan Rahimah and then ventured into general practitioner.
Any experience that you'd like to rate here?
I have few experience, but the one most stood out to me was a case of necrotizing fasciitis of a left thigh at the lateral side. So it's quite deep wound. So the patient was a young patient, no known of diabetes, but stayed with us quite for some time, 2 months, because it was quite deep. So she need a regular dressing. So we did a vacuum dressing for her. So yeah.
Vacuum dressing. Have anyone heard about vacuum dressing? Can you explain a bit on vacuum dressing? Also?
So usually, have you seen the aquarium sponge or not? So yeah, it's quite similar to that. Actually, we use the same ingredients. So we just make a hole towards the vacuum sponge and put 2 tubes in. So one to suck all the exudates over there, and then we will leave it for 3 days, and then we'll change the dressing again. So basically, it expedites the wound closing on the wound gapping, and also we actually can take a lot of exudates, especially when the wound is very deep. You will have a lot of exudates. So we don't want it to turn to slough or pus.
Great share. That's good. Fantastic. And just to add on about the dressing that you did, vacuum is also applied to improve the circulation. When you apply vacuum, you suck out everything so you can get regeneration, a new epithelialization of the tissues, right? So that's most important part. And of course, exudate extraction, right? Doctor?
My name is Bala. I'm a GP also. Started my houseman in Hospital Klang. Then my MO ship was in Malacca. But it's quite some time, some 20 years already. I'm in GP practice after that.
Dr. Bala, I don't have to ask you much, but you should have plenty of
so
experience
many
of this,
experience with suturing wounds. Sometimes we see bad wounds. But what I think is important for GP to follow some procedures, and anesthetize yourself and cleanliness, and you clean the wound properly. So I am quite happy during my practice. I never seen much wound breakdown or infected wound in my practice.
All right, that's great. Wound adhesion is important.
Yeah. Basic things that we follow in GP practice, we still have to follow that.
Great share, Dr. Bala. Thank you so much. Yes, Mr. Indran.
Good morning, everyone. So my name is Inda Warman.
Yeah.
I'm a third year medical student from University Malaya. Yeah, and today I'll be joining you all for the suturing session today.
I believe so. I believe they would have assisted some cases in the hospital, right? During your posting?
Not assisted, maybe just going into the OT and just observing. Yeah, it's
Yeah, this would be a good start for you, Inder. Okay?
Yes, doctor.
Thank you for
Thank
coming.
Thank you, doctor.
Great pleasure to see you here.
Hi, good morning, everyone. So I'm Alex. So I did my housemanship in Hospital Kuala Lumpur. Thereafter, continued my MOship in HDA as a EDMO before I quit out, and then continued in UCSI University Hospital as a MO. Then only I came to know Dr. Kiran and joined under him as a GP practitioner now.
He is my brother as well. Okay, thank you, Dr. Alex, being with us together. Been together for so number of years now,
My
right?
pleasure, doctor.
Excellent. Okay. Yes, doctor. Doctor.
Experience of the under the wound care is the most interesting one was diabetic foot ulcer, but under maggot therapy.
Megatherapy.
Yes, so it was a foul-smelling, sloughy wound. So very hard for us to debride the wound. So we could use the maggots to clear up all the slough and also all the dirty wound. So once the maggot already eaten up all the areas, so once the epithelialization tissues are visible, then we use the Manuka honey.
Correct.
So as a research for we see the evidence base how effective it is on wound healing.
That's a good share as well. Worms and maggots are commonly seen in our practice as well. Ooh, I mean, who happened to witness a worm? Huh? Doctor? Huh? Okay. Now you're going to talk about that. Okay.
Good morning, everyone. I'm Praga. Did my housemanship at Hospital Mum Sarawak, and then I got transferred to Hospital Klang also. Not much knowledge at Hospital Klang because I did in blood bank department, and then I got GP at Hospital Polyclinic MK also lah Telogong. I just only got 4 months of experience in GP side. Recent experience regarding the maggot also, it's a diabetic foot ulcer. Patient, I think like 1 month ago, patient just came with the diabetic wound for just 1 week. When we opened the dressing and then we noted some maggot, and we just did the basic wound irrigation and then just transferred, just referred the patient to hospital for the further management lah. Which didn't did much actually because that one need amputation actually. Then may after like 1 week or something, we saw the patient again after done the 2 amputation, and patient is still under our follow up for daily wound dressing.
Yeah, that's a good experience as well. Just to relate to the same, in my past experience, I was posted as a student in India back there in Davangere. I still remember. And that area used to be flooded with a lot of leprosy patients, right? And we were posted to leprosy ward at least for about 1 or 2 months. You just imagine these leprosy patients so pitiful that they come to the hospital maybe weekly twice and go back to the usual work, begging, right? So there they get exposed to flies and all those things. So when they come in, you can see tons, I would say tons, that's the right word, of worms. During those periods, I could say that, probably I personally would see about 10 to 15 cases. So take out the maggot, pick it up, okay, those things. But for the deep-seated maggots, they may not come out. So what is the best solution that we use? Take it out. Turpentine, there you go. Old-timers will know that. Pour the turpentine, everything pops out. Right, pops out, and then clean up, and then do it again. But anyway, it repeats again, and they don't feel anything pity, right? So we never realized what Dr. Alex related just now, those days, maggots could be used as one of the treatment, actually, right? So now, it's not that Dr. Praga referred the case just like that, so that we want the maggots to eat up, because those maggots are different, and what we see here is different, right? Totally different. They are cultured, they are grown up in the lab, right? So those are the nature, but even then, in spite of that, if you happen to continue the same maggot, cover it up, you can see a proper denuded surface. All right, it will be very red, right? Quite healthy anyway. So maybe you can allow that for about a few days, and then you take out the maggots, right? And then use Manuka honey. Right? Manuka honey is medical evidence, under medical evidence. Okay. I think with that, let me give you a brief introduction about myself. You don't mind? Right? Thank you. All right, I'm Dr. Elangkeeran, all right? Krishnan. I did my MBBS back in India in an unrecognized university called Davangere, JJM Medical College, Davangere. And I came back to Malaysia, like how Dr. Bala said, for the final year examination, USM Kelantan. I did my USM Kelantan. I got my second MD degree. Those days they awarded the degree, but now they don't. Because we used to sit for the exact questions, exact examination conducted by USM. So we were posted for 3 months in the hospital, and then we get our MD degree. I was lucky to pass, and that was tough those days. Anyway, it's a very bitter experience, most of us had. Anyway, next I proceeded with FRA CGP, Fellow of Royal College of Australian General Practitioner. That is a conjoint exam conducted between Australia and Malaysia. And with that, another award came along is Member of Academy of Family Physicians membership. So both fellowship and membership. I would say those who inspired to become a family physician should take up this one because the future is going into that, all right? But with the GP practice may not be really compulsory as long as you can cover up a lot of other aspects. Then proceeded with diploma. Before diploma, I did my certificate in dermatology from Academy of Family Physician, and I pursued with the postgraduate diploma in Bangkok, right? Then I took up diploma in aesthetic medicine, US, and then of course another one I did is fellowship in laser and cutaneous surgery from Bangkok as well. And then I did few other things. I had to do it because I tried to sandwich everything into my GP practice, all right? I did aesthetics, I did few other things. So together it worked quite well for me as a GP. Now, and then proceeded with ACNUM certified qualification, that is on nutrition, right? On nutrition, and also heavy metal and toxicity elimination. When you talk about heavy metal toxicity elimination, it's nothing but a chelation therapy, right? Chelation. I think maybe we can discuss that out later, chelation, but it is not. It's not. You don't use it in Malaysia. You don't practice that in Malaysia, except for selected cases with consent from the patient, right? It works on fantastic on diabetic patient, right? I did one for one of the affluent patient of mine, recovered from peripheral arterial disease, peripheral vascular disease, in about 2 to 3 months' time, and he could walk about 10,000 steps. Of course, along with the other hormone. So, talking about hormone, I did my hormone from Thierry Hertog, one of the renowned hormone expert in the world, right? He has his own hormone school in Belgium. So trained about 3 years under hormone, right? And I did just recently, I did my mental health from UKM, University Kebangsaan Malaysia. And about a month ago, I got my diploma in geriatric practice from Ireland, right? So this is my background, right? And all these things are very helpful for me to do my GP practice. So I channel all the knowledge as far as possible, as far as the God permits me, channel all the knowledge to help the patient. Doctor, without undue delay, right? I think we shall proceed with our first module. But before that, I just want to tell you that we've got 4 modules in total. Every module will have about 1 hour. Each module is subdivided into 20 minutes and 40 minutes. 20 minutes on the interactive lecture. That means we are going to interact together. And 40 on hands-on. Most of it focuses on your ability to do it, right? So with that, we'll take it in a systematic manner, right? And we'll try to finish all the 4 modules today, which we have to, right? Please bear with me. I know it's Sunday, but you'll enjoy the moment. I'll be a joker as well, don't worry. In between, I'll crack some jokes, okay? Yes, okay, fine, thank you. So, can I have the first slide? Okay. Yes, module today, the first to start, is on fundamentals of wound management, and we have to know what's the learning outcome, okay? What is the fundamental and what's the learning outcome? The learning outcome is to understand or to perform proper wound assessment. For the fact that if you don't assess the wound properly, we will end up in a problem, okay, which you all know. So I don't have to elaborate on that. The second thing is select appropriate suture materials, right? For nylon, superficial skin, and you know catgut where to use, proline where to use, Y-krill, all the suture materials perform and gives different function. Right? They are not targeted on one particular wound. No, definitely not. Then how do you maintain a proper aseptic technique? Right? That means to say you have to wear the sterile glove. Not only that, probably mask. Not only that, maybe your cap. Sometimes PPE. So you have all this thing in place. You are going to assure that the wound won't get infected, right? Although we don't do it often in the clinic. Okay. Anyway, the fourth that you need to know is demonstrate a proper technique. All right. I just got to know I just sneaked in. I heard somebody happens to hold, try to attain hemostasis just now, and the patient just shook the hand and was pouring out. Thank you, Dr. Murga. I caught you today. And the fifth thing is tying knot skill. How are you going to tie the knot? All right? Whether it is a knot that you tie with the needle holder or the hand knot. Normally, hand knots, we do it in the operation theater, in the hospitals. The fourth thing is how do you manage the wound care after having done all these procedures? Okay? So basically, to summarize, systematic wound assessment, wound types, phases of healing that we need to know, determine indication and contraindication for suturing. Okay? Okay. Now, can we have someone here, doctor, volunteer? I just want you to put up the hand. I don't want to call you by your name. Is it okay? So, can you tell me what is the worst kind of wound that you have seen? Have you seen any contaminated wound, doctor? Contaminated wound. Terrible contaminated wound. Yeah.
So I think I've seen one in MK Telugu. I mean, the initial wound, right? The contaminated wound.
Yeah.
Okay.
What do you mean by contaminated wound?
So he came in with actually a burn injury. But then he was splashed with some plastic material on the burn with 2nd degree to 3rd degree.
Wow, okay.
Yeah, so it was highly contaminated. So we had to carefully irrigate and scrub all the material off because it was burn injury. So we can't really scrub it off very hardly, just like a normal wound. So somehow we did it, and I think he was fine after that.
Right, fantastic. That's a good experience. Okay, great. So what we mean by contaminated wound is any wound above 12 hours, right, is considered contaminated. Right. What is your thoughts on it, Dr. Bala? Do you want to suture after 12 hours if you see the patient?
Irrigate, clean it, keep it open.
Yes, there you go. That is the actual practice. Irrigate the wound nicely, put in antiseptic, keep it open to review the next day. Right? So when you see the wound, perfect, there's a granulation tissues without any pus or without any contaminants over there or debris, then you can do what you call as secondary suturing. That is after how many days, Dr. Bala? Roughly? 3 to 6 days. Fantastic. Give a big hand to Dr. Bala. Right. The second slide that you see here is a clean wound. Okay, you know the clean wound, fresh enough that you have find some oozing blood. So such wound that's normal. That's what you normally see. And of course, contaminated wound will have rib debris, discoloration, right? Sometimes the periphery edges will be pale. So we have to know that. And then sometimes you have erythema. That means the redness around that place. That means spreading cellulitis. And that's a time when patient can have severe pain. Plus, they may have fever if it is 1 or 2 days later. Okay. Then you have punctured wound. Right? Punctured wound. Dr. Alex, I think you have seen punctured wound. Am I right? Yes. So give me some account on that. Come, Dr. Alex.
Especially in Telugu only, I've seen lots of injuries, especially from the industrial injury. So there was one puncture wound also. The case that we discussed together, Doctor.
Wow.
What was doctor gave some idea inside the input, then only we continued.
Yeah.
And the turnover was very well.
Excellent. So good healing. Yeah, good. We used to see a lot of cases. Yes, Dr. Alex had seen a lot of cases and did a lot of job on that. So one of the puncture wound that I personally saw is punctured through and through the bone. All right. And the problem with the punctured wound was normally in the industries, they don't use a nail which is smooth nail. No, they have that kind of screw type of nail. All right, screw type. And this is the worst part is it is one way going screw. You can't take it back. One way. I had one patient who had it over the heel bone. Came out this side. So that was one of the worst case. So what I did was, at that time, I beat it to go in further. Right? I anesthetized the area around. Bone is not that painful. I took the hammer, hit it back. It went in through and through. And then I cut the end of it, the screw part, cut it and then pull out. And then flush it with hydrogen peroxide. Keep it open. So these are the cases what we see punctured wound, bone punctured wound. Sometimes you have injuries, right? Injuries which are punctured. Like, basically, punch gun. There's a gun normally they use in wood industries. They just put a puncher, just like that, pop, pop. The whole thing comes out. You can see the punctured wound. Plenty of cases. So we should know what we do with the punctured wound. Again, what Dr. Bala said is right. Flush it nicely. Make sure that you remove all the debris. And here the scenario is different. You have to give antibiotic. Right? Antibiotic. What antibiotic would you choose, Dr. Bhavani?
Maybe Rosaline.
Yeah, Rosaline. Yeah, correct. So Rosaline for about 3 to 5 days, IV. All right, that would be fantastic. Cover up oral antibiotic. Try to put on broad spectrum antibiotic, augmentin with flagyl, which covers the anaerobes. That's what our practice is all about. So go and bantai, maximize your antibiotic. And if you happen to see anyone catching fever the next day, the case is for referral, right? Not to wash your hand, but that's what we do, right? Okay, you might need a strong antibiotic. Then comes to laceration wound. Clean laceration, fine, we can suture. Thank you. Next slide. Okay, now I'm just going to go in fast. This is physiology. Probably we can bring in our Inder to tell us something about this. Now, phases of wound healing, we have hemostasis. Okay, hemostasis is arrest of bleeding, right? Then you have inflammation, where all the cells comes and gather, accumulates over there, particularly the white cells. Okay, right? White cells, you know the function, right? Fine. And then you have proliferative stage. Then maturation and remodeling. Inder, okay? It's your choice. Can you tell me a bit on hemostasis mechanism? If you know a little bit, fine.
So hemostasis is the first stage. Yeah. So that's where we have the vasoconstriction, and that's where the platelet will start to aggregate, and then we start to have the platelet plaque to move on towards inflammation and so on, proliferation and maturation later on.
Yeah, that's a good one. Okay, let us convert this into medical perspective. In such case, that was described by Dr. Praga, all right, oozing without stopping. What would be the next choice, Dr. Inder? Compression. Now, what we need to know about compression here? Most important. How long going to compress? 20 minutes. Okay. What is the bleeding time, doctor?
What do you mean bleeding time?
What is the bleeding time? The normal wound bleeding time?
Not so sure.
2 to 7 minutes. It's okay. Cool. Pass, doctor. Next. So that's the time between which we. But you are right, doctor. Sometimes you need to compress for more than half an hour, 1 hour. The longer, the better. Right? So 2 to 7 minutes, you can arrest bleeding of any wound, most of the wound, simple wound, but you may need 20 minutes to arrest wound which punctured badly, particularly involving the bigger vessels. Right? So how long did you compress, doctor? Okay, Dr. Praga compressed for 10 minutes. Give a big hand. Good. She did a good job, right? Okay, good. So hemostasis is one mechanism, followed by inflammation. Proliferation is, repairing, neovascularization. We bring in remodeling, neovascularization, and finally remodeling. Can we move on to the next slide? Okay. Factors affecting wound healing. What are the factors affecting wound healing? How do you improve, how do you enhance the wound healing? Right? Very important. Wounds like infected wound, it will never heal. And we know diabetic wound, right? All of you know that. How long it takes for the wound to clear off or heal? Months. Definitely not days, months. Okay, so what is important here? We go back earlier slide, just think about it. the neovascularization can be compromised when you have not only low immunity but also what else? Low immunity and infection. Okay, neovascularization won't be found. In particular case like diabetic cases where you have, we call it neovascularization, new blood vessel formation, all this thing will be compromised. Okay, because the endothelial injury will always be there in diabetics. So in such cases, you can find the growth of the new blood vessels won't take place that easily, right? So the same thing goes here. Suture tension, this is important. Sometimes I do see open up, the edges are props up, but I never seen our clinic, right? From other clinics I've seen, right? Too tight. What happens when you put too tight suture? What happens, doctor? Dr. Ashini, you tight. I hold you like this, it's fine. Come, sorry, doctor, if you don't mind. I hold you like this, feel comfortable, right? If I crush you, what happened?
There's tension.
Tension, yes.
Tension. And then there's no space for the tissue to grow.
The blood flow is?
The blood flow is compromised.
Fantastic. Give a big hand here. Excellent. You got it. That's how we should know. You go and grip it so hard, the blood won't flow. And you open up, you see whole area will be gangrenous after about a couple of days. So that's why wound suturing is about approximation, not gripping them, right? Okay? And multiple sutures like this. When do you see people putting sutures like that? Sometimes cases do happen. Yeah? Jagged wound, they don't, there you go. Okay? Jagged wound like that, like this. So you have to put like one over here, one over here. But whatever you do, be it tension free. Okay? That's all right. Coming to the comorbidities which we just mentioned earlier. What are the comorbidities that compromises wound healing? What could be they? You have heard about comorbidities? Whatever whatever disease that an old man or young middle-aged man may carry, is called comorbidity. Like diabetes, hypertension, heart disease, kidney failure, right? All these things are comorbidities. When you see such patient, right, in practice or in life, they come with a wound repeatedly, 3 months, 6 months, and end up in amputation. A simple wound, right? Comorbidities like diabetic peripheral neuropathy, right? Whereby the nerve, function is compromised. They don't feel, they feel only numb. Sometimes they get the needle and pins over the periphery. So they don't feel anything, just walk barefooted and step on some sharp object. And they don't feel anything. After some time, they look into the bottom there, the whole area become gangrenous. And they'll never feel anything. For those people with a diabetic, do we give any local anesthesia to do the dressing? No, we just cut like that. Take out the whole chunk of food. They'll never have the pain because all the nerves are dead. Literally. Okay. So these are the things that we see. Next slide, please. Now, indication and contraindication for suturing. Right? This one we know, okay? Very easy. Beautiful, clean wound. The gapping is important. And then if it's less than 12 hours, all right, you can proceed with this thing, what you call suturing. More than 12 hours, as what Dr. Bala said, doctor, I won't do that. I'll just give another few more days. I'll clean the wound. I'll put an antibiotic. I'll look for the new formation of tissues. I'll wait for it and then I will proceed later as secondary suturing. Okay, so the contraindication for the wound suturing, right, is of course we know, repeating again and again, infected wound, puncture wound, devitalized wound, right? Puncture. So what do we do in puncture wound normally? We can't be referring all the cases to the hospital. Am I right? Okay, you can't be loading the whole job to the hospital. You have fantastic open puncture wound. Okay, Dr. Alex. What we normally do in the clinic if you have punctured wound? Come, doctor.
Meticulously try to remove, but then don't disturb the surrounding structures. Especially there's any structural exposure, must be very, very careful.
Okay, assuming that we have a puncture wound here, penetrating here without involving
The vessel.
Right, puncture wound. So how do you handle the wound? Any idea in your experience?
Actually, one side we have to seal it, doctor.
No, I'm talking about both the sides puncture. Through and through.
we can slowly evacuate.
Fantastic. It's a good one. You know, like doctor advised, we can open up like that. Fine, right? Dr. Bala, any idea about that?
Puncture that. If it is clean, and the material is not rusted, it is clean. It's clean. And just open up the entry point, exit point, and then use this hydrogen peroxide, clean it inside, open both the.
Okay. Anything else, doctor?
So
How do you follow up?
So once we flush it, we just keep it open
Yeah.
and do dressing until it gets with broad spectrum antibiotics.
Right, okay. So you intend to pack it up?
If it's quite big, we can pack it up with some povidone soaked.
That's a good one. Okay. Thank you, doctor. So packing of the wound, that's the important part. All right. If we were to pack the wound, is it going to be under tension is important. We try to pack sometime like, you cannot even, it's so tight. The same thing, the grip. So we don't pack it so hard. So just make sure you take one gauze, make sure it goes in smoothly. Use salt pack or povidone pack is what Dr. Bhavani said. And then leave it there for a day, remove it. So you are going to assess the pack, the material that you use for the next day, whether they got debris, pus, or whether it is pouring, oozing with the blood. So that is one way of assessment. We might see, because it's a punctured wound, you can't see using a teropong or anything, right? So, but how do you assess the wound is healing or not? The only way is to observe, okay, it's red today, day 3. That's how. What Dr. Bala said is fantastic. Doctor, I have a puncture wound, if it's close to that side, I'll puncture it further. Fantastic. But if its wound is big enough, we flush it, it comes out, it's just nice. But the wound which is through and through, you have to flush and make sure the other side it comes out. Alright, so through and through. Right? With the precaution not to injure the vessels, the blood vessels. Why? The moment you injure the blood vessel, you're going to introduce everything to the body. Give adequate antibiotic cover. Okay? If you're not sure what is the best thing to do, refer. Right? So, next. Okay. Now, after this, we'll be proceeding with hands-on. But before that, let us go into a bit of discussion on the preparation, right? What we have learned about, right? Hemostasis in particular, because hemostasis is one important thing that if we can understand, I think we can manage a lot of cases, right? Okay, doctor, this is more of interaction, right? Okay, so therefore, I'll ask you, each one of you can volunteer. Let's say if you find the bleeding isn't stopping, right? Bleeding isn't stopping. Once you give once you provide the answer, pass on, right? So bleeding isn't stopping. What is the next move that you might attempt? One is compression. Anything else, doctor?
We can give adrenaline compression.
Explain that, how you go about.
So usually we'll take 1 ampule of adrenaline. So there is 2 ways. I've seen in hospital, sometimes they'll pour directly to the wound and then they compress with gauze. We just hold the same as compression dressing, but it acts faster actually. But if you are pouring adrenaline towards the digits, that means you have to be careful, can cause vasoconstriction, can cause some necrosis if you're not careful with it.
Okay, Dr. Alex, any comment on that? Any feedback?
Yeah, the same way, doctor. Sometimes they do the medical pour it directly. Sometimes they will mix with the saline, dilute it, and then they will.
Okay. All right.
I see like we take with the gauze. We soak the gauze in adrenaline. And then we do the compression, same kind of compression. For some time. Vasoconstriction is stopped.
Dr. Praga, any feedback on Dr. Bhavani's statement? You mean to say nothing is wrong, right? I accept that. Give a big hand for all of you. Nothing is wrong. But there are a few things that we need to know. In case we are going to give local infiltration, Dr. Alex, you don't mind answering? What is the proportion or mixture of adrenaline with liquid?
1 to 1 ratio to 1,000.
It's okay. I'll just give you a bit of a hint on that. 1 to 1,000 is the normal adrenaline, right? Normal adrenaline concentration. So how much do you take to dilute?
Oh, 1 cc to 9 cc of saline.
Correct, 9.9 cc's of saline. How much of adrenaline? One, no, one, not 1 cc. There it is. Okay, so that is the amount. So if you go to inject overload, what is the complication can you have with the, what is the adrenaline effect? Vasoconstriction local, but if it goes systemically, cardiac arrest. So what do you have to do? Pull in the plunge and see whether you are in the blood vessel or not. That's the most important thing. Okay, so that's called hemostasis. Right? Hemostasis using adrenaline. Okay, some doctor practices packing. Okay, some of us practice local infiltration. Right? I've done quite a good job on that. I had to give a whole face adrenaline injection. It's called a Thomason solution for me to lift the lifting. You know, called face lift, the chin lift. So where you hook on to the thread to the sternocleidomastoid muscle and it goes inside, tarik, and then another puncture here. It's crisscross lah. Then you pull it up. So that one we use this Thomason solution, combination of cocktail of lignocaine, adrenaline, all those things with the normal slide. So you inject slowly, infiltrate everywhere, and then make sure full. So it takes nearly about 30-40 cc. 30 to 40 cc, seriously. So that is where we have to use adrenaline. Mind you, what Dr. Bhavani said is right. You trying to play with adrenaline in the wrong place, what happens? Gangrene. Simple, put it away, gangrene. Fingertip, any tips lah, for that matter, right? So be careful with that, right? Okay, so next. The next thing is, wait, no. Before. Belum lagi, itu belum sampai lagi. Okay, 20 minutes. So now what we do, we will go on hands-on. Alright, hands-on. So before we go to hands-on, before we go to the slide, I invite our Dr. Praga to come with a gloved and masked face to come and perform the wound assessment on our model structure here. Is it okay, Dr. Praga? Are you motivated? Big hand again. A better hand, please. She's the first presenter here. Right. Dr. Praga, you have your glove. Thank you so much. Now you do the talking, Dr. Praga. I'll give the mic. So once Dr. Praga has done it, we are going to turn it on to you. You are not the only victim, right? Okay. So we turn it on to you, where she will also accompany one of you, and have you identified your partner? All done. You see, fantastic. That's a good one. So she's going to do, and later she's going to help others, right? Doctor, I'll hold the mic for you. I have the privilege to do that. Okay, you are the expert. Excellent. So this is the wound being presented to you, right? I want you to explain our brothers here, our friends here, what kind of assessment you're going to do, all right? So, can you proceed? Thank you.
So, before that, once we receive the case, we should ask the further history. What kind of injury was that? What time is that? Is that less than 6 hours or less?
Doctor, we are done with the history. Thank you so much.
And then, when we assess the wound, right, should know the location of the wound first, and after that, I need to know the size and depth of the wound and what is the type of the wound.
Take your time, doctor. You've got another 10 minutes on you.
Okay. So this is active bleeding of wound, and then the edges are not symmetrical one. That's jagged wound. Don't have any foreign body. That's noted here. The edges are asymmetric.
You don't need any instrument to assess, doctor. Maybe the depth.
To measure the depth, you can use the cotton bud.
Right. Can we have the relevant instrument? So Dr. Praga is charging up now. Give a big hand. Motivate her. Doctor, here comes. Assuming this is your cotton bud, which normally see, we can use this for hold it, and then because it's sterile, right? So fine. So you can assess. You can touch the wound. It's yours. Measure. You measure, doctor. Tell me what is the measurement. It's okay, roughly, rough estimate.
This one around 6 to 7, 6 to 7, and then the width is like 1 cm like that, and the depth may be 0.5 cm.
Around about 0.5 to 0.8 actually cm or millimeter, right? How's the edges, doctor?
The edges are not symmetrical. Here goes rugged one.
Good, good. Anything else, doctor? So Dr. Prakash has done a good job. Okay, she's basically explained about the edges, the depth of the wound, the length of the wound, right? Most important thing is location. Where is it? That's important. Yeah, doctor. Right. So that is another thing. And beyond that, she's seeing some bleeding over there, active bleeding going on, and she saw some foreign bodies. I mean, no foreign bodies according to her, and a lot of things she has spoken about. Okay, so doctor, can we pass it out to them to do it? Let's assess how they do it, right? So you're going to company one. Each of you in turn will be assessing and telling each other. Is it okay? Can you do that, please? So with that, your glove is there, your mask over there at the back, right? Please wear the glove from the box, right? And you have your own wound, you assess. So each of you will be giving your assessment point, and we will discuss about that in detail. Come. Since Dr. Prakash has done it earlier, okay, so we applaud her, and now it's Dr. Alex's turn to do a running commentary to Dr. Prakash on the wound assessment. Is it okay? Fine, but carry on. Start with Dr. Alex first.
Possibly an acute wound because of cut, or is an injury because there's a presence of foreign bodies such as sands and also stones. And then the size of the side of it, we have to identify the side. And then the size measuring approximately 7 times 2 cm. And then it is a linear called reservation wound. And then there's a presence of bleeding over there, and no structural exposure, especially vessel or tendons. Other than that, it's basically it's a contaminated in a wound.
Fantastic. Give a big hand. Okay. Now, Dr. Harshini, it is your turn to explain about the wound to everyone, as well as Dr. Bhavani. Is okay? Okay, good. Just tell about the wound. Just what you know. It is so length. Okay, hold it. Talk about it.
So it's a single wound that I can see here, and then the side of it, and also the edges of it is sloping, and then there is active bleeding, and then the base of it is covered with blood, as well as there is no foreign body that can be seen from this wound, no pus, and also no odor that can be smelled.
Yes. Hello? Yes. Hey, that's great, lah. Fantastic for Dr. Harshini to present to her, huh? Right? A bit, it's fine, good, excellent, doctor. So this is how you're going to bang the hospital soon. They're going to be scared of you. Dr. Bhavani in turn. Explain, please explain.
So this is a clean cut wound. Hemostasis has been achieved. There is no active bleeding for now. So I will say it's about superficial cut wound measuring about 2 times 7 cm. There is no foreign body, no pus discharge, and no underlying structures exposed such as muscle, tendons, or vessels. And Of course, there is no chemical or any foul smelling odors.
Yeah, doctor, fantastic. Give a big hand. He also smelled the wound. How many of us do it? You told that. Oi, back to Dr. Bahar. Not for you, doctor. This is Harshini, right? Harshini. Fantastic. That's what we normally do. Huh? I remember yesterday I had a case. No, day before yesterday. There's one knee effusion. Right? One of the patient presented. You saw that, right? So you take and you smell it. Thank you so much for reminding me. Good. Okay. So thank you, Dr. Bhavani. Thank you, Dr. Alex. Come. We have our senior brother here, Dr. Bala. I don't expect Dr. Bala to explain. I expect Inder to explain. Dr. Bala to comment. Now, Inder will explain. Dr. Bala is going to comment on, give a feedback. Okay? Right.
Okay. So, it is a single cut wound with a measurement of 2 by 7 centimeters, and there's signs of erythema surrounding the wound. No signs of pus or any signs of discharge that can be seen. The base of the wound is, I would say, still bloody. There is active bleeding still going on. There's no everted edges. It is a sloping edge wound, and yeah, and there's no signs of any foreign body or any pus that can be seen.
Okay. Can you pass the mic to Dr. Bala? Dr. Bala, please comment on our future doctor, what he has done. Good. Good. Anything you want to add upon? No. Please tell. Let audience, everyone listen.
Just miss about the depth of the wound.
Okay.
Except for that, everything went good.
All right. So everyone is satisfied in this answer, is it? Anybody, any doctors wants to top up the information? Anything else, doctors? Foreign body was mentioned, right? Okay, good. So that is fine. Dr. Bala is just an assessor, another assessor, like a big person. So he has found Inder performed very well. Okay, big hand for Inder. Okay, good. We are having a lot of intelligent people who is going to govern the Faculty of Medicine in future. So Harshini and also future Inder, right? Okay, Dr. Inder, future, right? Thank you so much. May you all be seated. All right. So I'm going to do a basic assessment on the wound, all right, which was seen earlier by Dr. Praga. Okay. Right. Can I have a glove, please? Can I have glove? 2 gloves. Wound examination per se, when we have a model, that is not a model. That is a patient himself. Right? This is how we have to assume. Right? So this is a patient. So what all of it done excellent. Okay, tremendous job. But we just observe from the top because the feeling of this being a body part is lacking. Right? However, Inder was okay, fine. More different way that he is a student now, so he could present it like a student format. Okay, so fine. So generally, when we go to the wound inspection, right? First we start with inspection. Next is palpation. Definitely not auscultation here. Okay, right. So observation. All you have done. You are all perfect. Excellent. All right. No surrounding erythema, the wound edge, ragged wound, and then the depth, the length, the gapping, wound gapping, the kind of wound that is opened up, okay, everted, eversion wound, all are perfect. All right. And there's no other issue. Our Inder mentioned that there is no surrounding erythema. Okay. That goes to say, talk about infection anyway. So nothing there. But another thing that we always have to remember, the wound assessment also based on the parts which is affected. Parts. For example, if this same wound is on the leg, right, what we'll be targeting of the same wound is in the hand. Is the examination same or different? Yes. Can you please give what is different when I find the infection wound over the dorsum of the hand? Can you please pass the phone? So what it differs, doctor?
So usually we'll see the distal pulses, whether it's can be palpable or not,
Right.
and then whether the sensation is intact,
Yeah.
and if there is any tendon injury.
There you go. That's it. So assessment of the wound differs from part to part. I feel maybe it's my failure to tell you what part is this. Or maybe I could not go in and explain you, oh, this is the hand. I never told you that. However, that is the right answer, and I assume everyone knows the same thing. So on that basis, inspection depends on the movement, tendon cut, if it is there, and then area which is involved in that. Is it up to the subcutaneous tissue, or just involve the superficial skin, or it also involves the deep fascia, and also the tendons inside, or the bony surfaces, or penetration through the bone. All right, and then assessment of the tendon, flexor tendon, extensor tendon, all these things are involved, right? And mainly the function of the hand, right? So all these things has to be assessed completely. You all are doing the same in the clinic. I'm not saying you're wrong. Please, you're doing it. But only thing is, when it comes to such thing, we tend to forget. Am I right? Just to mention lah. So we have got a stage problem lah. But just mention to you, it's not a stage, it's a flat surface. Huh? Okay, so on that basis, number one is inspection, right? Inspection. So we are done inspection. Perfect. We look for the foreign body, everything. Okay. But the second thing is what, doctor? Palpation. What do you palpate here? If it's a hand, Dr. Bhavani told us, oh, we have to, definitely we have to talk about it, palpate the peripheral pulses, okay? Definitely you don't find tekan like that, sakit tak? Sakit tak? We don't do that, right? Okay, so be gentle with the patient lah. So gentle, ada sakit ke? Oh, okay, tak apa. Memang ada sakit sikit, tapi tahan ya, tak ada masalah. Doktor nak cuci dulu sikit, alright? See, you can't palpate, you can't inspect if you just inspect the blood. You have to do what? Clean it up. Have you all done it? It's a failure. You should have requested for cotton. Can I have a cotton? So now I'm going to clean it up. Okay. What I use for cleaning in the first to start with? What? Infected wound, thorough wound, okay lah. Anything else? That's the thing. Full stop. You want to see a proper wound, the color, the texture, don't use hydrogen, because the hydrogen changes the color to frothy, right? You fail to see anything there. All become whitish, right? So always remember, use high water for this thing. Next phase would be, we bypass the clinic lah. Okay. What mahal juga kan? Okay. So now I'm just cleaning up the wound. Okay. So I've cleaned up the wound slowly. I use water for irrigation. I pour it nicely. That's why we have this kind of material, absorbs quite a lot of quantity of water, right? So they will be pouring up. Be open on that. Okay, basically, you don't bother much about quantity here. You're just missing water. But the most important thing is irrigate out all the debris, right? Debris. So then you clean up. Use a cotton. You can use hydrogen peroxide, as you said, or you can use Usol or Povidone. Povidone will change the color, right? If you feel the wound is badly infected, you're seeing after 12 hours, might tell use Povidone as well, and also hydrogen peroxide. Right? In our cases, they are very contaminated. All the guidelines being shown in the books are on the basis of what the Westerners writes. Right? It's a British this thing, London this thing. There they don't even have cow walking around, dogs walking around, or cats walking around. So we have to be more adaptive. We know which should adapt. Right? So we can't be following the system which is being introduced in UK and we follow. Oh, no, we don't. That's what happens in the hospital. Kenapa itu doktor buat Povidone dressing yang mana boleh ya? Come and see Teluk Gong lah. Right? Roadside wound, contaminated feces. Right? Feces. So that is the only thing that we have to be very careful about. So now, after irrigation, I use some hydrogen peroxide if necessary if infected, or I use Usol. Then I clean up inside. So once I clean up inside, we have to be very gentle because it's very painful for the patient. Okay, very gentle. Then I put it here, somewhere here, and then I inspect. Right, look for foreign bodies. This is inspection. Second thing, what I should do? Palpation. By this itself, I palpated. But yes, I used to have finger. I used to use finger. Why finger? Why not the instrument? You told me, Dr. Praga, I use cotton bud. We don't use cotton bud, yeah? But we can use cotton bud for depth, fine. But the finger is feeling. Finger is feeling. That's why we go into the deep depth of the wound, we feel everywhere. What is that, huh? Eh? I can feel something here, lah. Let me see, huh? Can I have a proper forceps, huh? So I could feel something, lah. What is that, huh? Oi! Foreign body, leh? Dr. Praga, what did you miss? You missed a foreign body. Give a big hand for that. Okay, so this is what happens if you just go for visual inspection without cleaning the wound. Okay, so you got the point. Yeah, purposely, doc. It's not to catch you. That's why you were caught in the beginning. You know, like I made a point that you come in. Okay, so fine. So this is the wound. What do you think would happen if you have this kind of material in the body? Yeah, worse still, huh? Infection. So open wound is not only inspection and suturing. Some of the wound require, of course, observation. You may even miss it if it's deep-seated. Ask the mechanism of injury. Penetrating wound. Tapi saya sudah keluarkan. Sudah cabut tarik. Are you going to leave it? Trust him? What we do? X-ray. X-ray to rule out foreign body, right? Dr. Bala is pity, doesn't have X-ray. Dr. Bala can't control. Okay, so that's the way. That's right. I hope I explained certain things about the whole thing. Now we have 15 more minutes. Let's go on with the slide. Okay, is it okay? Right, let's see how the assessment is done. The first slide. Okay, can you see the type of wound here? Assessment of wound edges viability. If you see the wound edges, you can see that the area around the edges, are they pink or red color? Doctor, how it looks, doctor? Here, this area. This is the wound edges, right? If you see this kind of a wound, Dr. Alex, what type of wound is this, do you think? Just rough estimation. Healing wound, okay. Dr. Bhavani? Ulcer. I think she got it right. It's a chronic ulcer, right? Seriously, looks like that. Why? Yes, injured edges are inverted inside. It is not open, it is not bleeding, right? Plus, you can see some slough there. Here. These are slough. Or this could be some fatty tissue as well. But the base is quite good. New granulations is taking place. Right. When you see granulation here, what it sounds? Dr. Bhavani is right. Chronic wound, but poor healing because the edges, what Dr. Bala said, they're all rolled in. And here, there's a little bit of erythema, not that clean, right or not? So this is a ragged wound, but this is a chronic wound. Viability is slow, all right? Okay, what we do normally with this case, if you want to promote healing, already done, Doctor. If you slove in, it will be a problem. So because this is clean, so we don't want to slove it further because granulations are fantastic. So what about the edges? It's not growing in. Dr. Bala, what do you want to do? Yes, scrub the edges. Scrub it and make sure that area bleeds. The next day, you apply some Socoseril or maybe Curozine, it will be grown. Okay, so that's one part. Okay, this is the wound. These are the type of wound where you try to avoid packing with povidone. Povidone will kill their growth. Okay, so that's important. The next wound here, we see this is worse still, quite a bad one. But the assessment of the wound is fantastic. You see, it is going in, rolled in. The edges are inside, deep inside. That means it's quite a troublesome wound, Quite tough to handle this, right? This kind of a wound, we can give a packing with Usol and then let it grow again. Again, use the Solcoseril, growth factor, we call it, or Curozine, right? But here, this is at the heel. This is a heel, right? You have a bony prominence inside, the calcaneum, right? It is going to take months to heal. So what kind of a dressing that you want to give for the heel ulcer, Dr. Alex? Povidone, okay, give a big hand, it's good. Povidone is fine. But it's bone, lah, Dr. Alex. Won't be any growth once you put Povidone. Okay, kerosene is fine. That's the one. That's a better answer. Anything else, Dr. Pranga, you want to say? What do you think? Heel la, wound, chronic la, bone underneath. You want to do something that so that heel is nothing but he's going to walk like this. He's going to apply more pressure. It's not going to grow. Dr. Wani. Okay, gel, fantastic, but still you go to pressure. Apply pressure, right? Little bit reduction. Silicon, you almost close, Dr. Bala. You challenging me too much, you know. There you go, you got it, brother. Big hand, please. Right? That's why, very bad, no, senior people. Right? Okay, good. Buy the silicone gel, similar to this or bigger. Put a hole down there. Pack it with Dr. Elangkeeran. Right? Done. Sorry, kerosene, right? Okay. This will grow better. You have to elevate the pressure. Okay? Fantastic. Now, next. Here, you see, wound tension. Right? You have to evaluate this way, not by holding with the hand. Use two forceps and then try to stretch it towards the center. So that's the tension you can see. Sometimes when you bring it in, when you try to bring it in, you cannot bring. Sometimes I've seen sutures, they put the suture in between of the gaping. Not gaping, there's a gap inside. That means they have done a wrong incision. They, instead of cutting like this, a narrow, they won't bump. Macam ini lepas tu nak join. Mana boleh? Cannot kan? Betul tak? So that is the thing. The way the sutures, you see, this is fine. The next one is okay. You don't have gapping when you try to suture. But here you see, the gapping is bad. Alright? There are instances where you might have to cut like that. But then you don't have to suture. Leave it for a few days. Let the granulation takes place from the bottom. Right? That's how we go. Next slide. Okay. Now the hands-on, the actual way, better than what we did, or probably better than what I'm still not great lah, or what we did. You see here, wound cleaning, irrigation, water, and then next is followed by proper cleaning with the Povidone, Usol. Okay, thank you. Next, Anna. Right. These are the preparation lah. First and foremost, hemostasis. Dr. Inder mentioned earlier, and he gave a fantastic explanation on hemostasis, right? Next is clean the wound. You see the way they irrigate, ample of water, ample of normal saline, sterile normal saline. Okay, some may go and ask them to put the leg into the shower. How many of you done it? Quite. Okay, so how many of you have done it? Cik Ana suka buat benda tu. Pergi cuci dekat Siki. So, siapa yang pernah buat? Semua ketawa What you all say right. People come with the soil, with the contaminated toilet stuff. From top to bottom, you can't be using normal saline, right? Not for the quantity, not enough to flush out. But all the debris there, best thing, ask them to go and do flush with water, but of course, taking precaution because it's not a clean water anyway. Tap water is not clean, but no choice. But immediately after that, irrigate with ample of sterile normal saline. Okay? Then you go for other form of solution. Okay, so that's one. Then you apply antiseptic. Clean up with antiseptic. Right? See the way they do it? Disinfect the wound area. Then followed by drape the wound, surround wound. Okay? So of course we are not here yet for that. Then sterile drape for sterile field. Not to expose other areas lah. Because when you are going to do suturing, the hand will be touching every part of the area, right? Indiscriminately. So you have to make sure, even if your hand falls or touches any other part, you are not going to contaminate, bring in the contaminant into the center. That's it. Fine? Clear? Next guy. As usual, we have done something amazing that we have now on discussion a little bit after that. Okay? Don't mind? Okay. So now, any other things that you want to add upon on the wound cleaning part, assessment part? Now I want you to talk for about each of you to talk, right? Assessment of the wound, how it's being done in the hospital. Is it okay? Boleh. Dr. Prakash to start. Normally, in your practice earlier in the hospital, how the wound is assessed. And the best deal that if you can tell me, some of you would have attended this plastic surgery. Right? Plastic surgery, right? How the champion, the specialist come and assess.
In the hospital, usually as what Dr. Kiran said, you need to irrigate the wound first to have the better view. And with the normal saline, usually copious of normal saline. And then assessment, it's what we did just now. Have to see whether got any foreign body, how's the wound, the size, the length and depth, everything. Is the neurovascular is compromised or not? And any further imaging that need to be done or not, like X-ray. And then everything for the management, I mean, need to open it or leave it. So
Very satisfying answer for me, right? Good. Next, Dr. Alex.
To add on Dr. Pragash's points, usually before the rounds, we have to open up the wound and then cover with a green towel. So after the specialist round, so they will give the plan. So whether they want to do to see the vascular, whether compromised or not, they do sometimes the Doppler to see the vascular flow, and then they will see whether it is infected or not. They want to do any swab on the wound or not,
Right.
wound swab. And then they want to, then while awaiting for the swab result report to come out, they will start with any broad spectrum. And then they want to do blood tests also to see the CRP level, whether increasing or decreasing, or whether their treatment is responding well or not, effective or not. Usually like that.
Thank you, Dr. Alex. A very in-depth explanation. Inder, if you've seen any cases being handled by your specialists.
Yeah, I've been in the wound clinic once. So we assisted on seeing a burn wound. Yeah, so patient came in for a redressing again. So that was when we are taught the right techniques. They mentioned more about the aseptic technique, how important it is to wear the apron, hand wash, and the way you open the wound kit, and then the way you I would say clean the wound. If it's a circular wound, it would be from the middle till the outside, and then away from you, right? And yeah, and also the way we handle the patients. The patient would be in pain, comforting them and all. Yeah, and I feel the most important part is the aseptic technique that I've
rightly put by Inder. Good. We are going to do it in the third module about cleaning the wound, right? So that is an important part. So how we clean? I think it's third module, more on before suturing, right? Thanks for reminding that. So Inder has given us a tip. John, make sure that we follow that. The way we do the dressing is important. Okay. So that's what going to be assessed after that. Simple assessment. Dr. Bala, anything else, Dr. Bala? You are like me, outside world.
Compare with the hospital. Hospital setting, what I see, they use more aseptic techniques.
Right.
When we have a wound, like these covers, they have a sterile green cloth.
Correct.
Which I think in the GP practice, we already run it a bit.
Good. Dr. Bala, thanks for reminding. You know why? GP practice is totally compromised. Right?
And I see.
And in spite of doing without a 100% sterile technique, aseptic technique, we still manage to cover the patient very well.
Yeah.
Right? Without any complication. I think 99% of the GPs are doing a good job. Not necessary that you have to have the kind of a thing, like environment, those
Probably
things.
they see more variety of cases.
Yeah.
So they maintain you must wear an apron.
Correct.
You must wear a mask.
There you go. Dr. Bala got it right. Give a fantastic
compromise.
Yeah, fantastic. Yeah.
And one more thing I see, they use copious amount of saline, normal saline. They have bottles of normal saline, and the ways we pour, which we cut costs in practice. Yeah. So, even though that, I think we just don't compromise the care for the patient quality. If we can do things well, it's okay.
Dr. Bala, fantastic.
Thank you.
All our aspiring GPs, future GP, current GP, right? If you want to cut the cost, Dr. Bala said, use copious amount of normal saline, right? That's good job. But again, in a GP practice, back to you, the Logong area, the Klang area is totally contaminated. Put a point. We don't have to follow what is in the guideline, right? People go to the hospital. Yes, you can monitor them for 10 days there. Yes, you can ward them. Yes, you observe them. Yes, you have nurse in rotation. Yes, you have aseptic technique because Dr. Bala said, this doctor go and search around, when seek around all the other patients, treat them, come back, they have to cover themselves. We are only seeing patients there. Of course, we see number of patients as well. The most important thing is, one is cost-cutting technique. The second thing is patient safety. So what we are doing is, I think, is justified, right? Dr. Bhavani.
Right, to add on the aseptic technique in hospital. So in GP setting, we mostly use non-sterile glove for dressing.
Right.
So there usually it's a compulsory to use a sterile glove
Right.
for dressing. Another one more thing, they usually for wound inspection, they usually have a classification for the dressing, whether it's a dry, wet, necrotic, wet gangrene, dry gangrene, and also whether there is a healthy granulation tissue.
Right.
So based on that, the dressing plan and also the dressing frequency changes as well.
All right.
And also they have a very tight glycemic control and monitoring, which actually in GP setting is not really it's not optimal, but we can't really charge the patient for every time for the sugar and everything. So the monitoring in hospital is much more better in
Right.
that sense.
Doctor, thank you so much. What she says is right. We are tight. Our hands are tight. Nevertheless, again, doctor, we are doing good job. We just take one fasting blood sugar in the morning. We get to know 5 to 6 fasting blood sugar millimole per liter. We are done. We can do it, right? So we don't have to do other things for that. For the fact that a lot of patients, I had one patient. I just want to tell you the experience. The patient came from the hospital, orthopedic, and she was advised to take away, amputate. I don't know how many of you. Alex was not there, right? You were not there. I don't. Not your turn. Before that, this is about 5 years ago. Patient came in with AR discharge, came to the clinic and started crying. Doctor, do something. Young old lady 60 plus 70 around that. And then I said, I can't do that because the doctor asked you to take it off, right? Basically, it was toe gangrene, right? They asked to take toe. She refused. Then it spread within 2 days, 2 to 3 days, went up to the foot. They asked to foot amputation. Then she stayed there. She didn't want to give consent. They said below knee. Then the last, they say above knee. She took AR discharge, came to my clinic comfortably, right? You know how the gangrene looks like. Everything is shriveled, you can see the alien, discharging pus underneath. The whole foot bottom, you can see swollen and just boggy down, okay? And I said, I cannot do that. Tolonglah doktor. Tak apalah kalau macam itu, saya balik mati lah. She cried, She said, what the hell lah? Encik, tolong dengar ya. I will do, anything happens, don't blame me. Is it okay? Then I have to start the patient on insulin. Okay? Taper down, make sure the insulin is given regularly. I use Novomix 30, fantastic. So start on that, put on antibiotic, put on vitamin, everything. Advise them to go on massage, leg and all. These are part and parcel. Then I cut the bottom, the dorsum, drain out all the pus. And then I took the hydrogen peroxide, just put one bucket there, put the leg inside, pour it. One whole bottle is gone. Then I took the glove. I just stripped off all the deprived skin. The whole thing came off and 2 toes are standing without the skin. Only the bone. From there, it went on. Nearly about 4 months for me. Everything grew, but I lost 1 toe for her. Finally, she was there living about 4 years. Then she had some other complications. She died. When the patient gets diabetic gangrene, the heart, the brain, everything is in trouble. Better to scrutinize and do something about it. That's why we have to target as GP. Okay? So with that, thank you for the first 1 hour successfully conducted. I hope so. Right? Was it a nice thing to do this? Tiring, right? Bit tiring. A lot of things. Good, excellent. Thank you so much. We'll break for 5 minutes from now and then we continue with the module 2. Okay? Thank you. Now it's a time to identify your instruments. What we knew earlier was wound inspection, observation, palpation, all those things, fine. So now we go into second module that is on suturing materials, instruments, And the learning outcome for this would be, we need to know what is the appropriate suturing material and needles required, identify the suturing instruments, and demonstrate safe, sharp handling. It's not important, it's not only enough for us to know, oh, these are the instruments, but how we're going to protect ourselves, right? Next slide, please. Okay. Now, every one of you would have seen variety of suture materials, okay? And I will just immediately go into you to find out from you, okay, what are the varieties that you have used, and it should be interactive. Or you have your mic here, doctor. So when I ask you, probably we can share the mic, okay? So with that, we have absorbable and non-absorbable suture material. Absorbable means it is absorbed into the body and made into a part of the body, maybe disposed by our immune system. Non-absorbable will never be absorbed, but it may stay as granuloma in the body and it remains there, right? We don't know whether it will remain forever. Yeah, possible, until he dies, right? Okay. Most of the suture materials that we use for the facial reconstruction, all right, underneath, we use absorbable inside the face, not the outside. The skin needs to have non-absorbable. So, but inside. Okay, forget about the suture. Now you know the fillers, right? The hyaluronic acid fillers, facial augmentation, cheek augmentation, all those things. They use hyaluronic acid. All right. It is supposed to be blending with the skin inside. I mean, I'm talking about the structures inside. Our content, our skin, our tissues inside. Okay. With that to say, normally it's expected that it can dissolve and then be a part of the tissue and gives you a nice look, perfect, good. But have you seen some people come with the blob, knob-like face? Knob, everywhere you can see like guli one. What happened? I don't want to mention anybody's name here, but you can see it's uneven, ball-like structures everywhere. It is bumpy. You touch the skin, you feel like, your hand, you become jittery, like that. It's not smooth. What could be the reaction there? Yeah? Yes, doctor? Granuloma. That's the right answer. Not everybody can have a normal situation with the instilled substance into the body. Everyone reacts differently, right? Everyone reacts differently. So with that in mind, we have to also be taking an account on suture material. Suture materials, you have to understand them thoroughly, without which I don't think we can even touch the suture, right? Okay, all of you are experts, I know that, but there are certain angles that we have to improvise, including me, including everyone, okay? So all of us are going to have some knowledge on what we are going to see and learn here. Okay, now absorbable sutures, as I mentioned, they are absorbed. There are a variety of sutures, all right? Vicryl, right? Vicryl. You can have a look at the vicryl on your table. Just have a look at it, all right? All right, Dr. Praga, what do you read there? Yeah, 3O. So Dr. Praga's vicryl is 3O. Yours also same, doctor? Why don't you have another look at the other suture, if you don't mind? What is it, doctor? What it reads? Yeah, catgut, absorbable. It is a natural catgut. Okay, that is a difference between natural catgut and one more catgut. What is that? Synthetic, no. I don't think so, synthetic. They call it treated catgut. Chromic catgut is treated. Okay, that means the difference is this is raw. Where is catgut obtained from? Raw material? Should. Cat. Meow. Which meow? No. It is sheep intestine and sheep collagen. Okay? So, come in there. Take your other stuff. What do you see here? What? Why monofilament? Fantastic. You got it. One filament, doctor. That's the reason. Okay. Good. So one filament. You are right. So what is multi-filament? More than one. You got it right. Big hand, please. Okay, good. So yes, intertwisted, intertwined filament is known as, right? That means number of monofilament combined together, it brings out one multi-filament, whatever you call. That is same. Nylon, they don't mention that. This is monofilament. The difference between mono and intertwined or integrated filament, Dr. Bala. What is that, Bala? What difference does it mean? Mono, almost there, is more towards slippery. Okay. So Dr. Bala mentioned slippery just now. Why are you laughing? Yes, monofilament slips easily. And when you suture, okay, slips. Multi doesn't slip because it is twisted stuff. Easy. Would you like to take the Vicryl or Prolene? Can you check with the Prolene suture? There's no Prolene suture, doctor. So you have to go back to Vicryl. Come, go ahead. Vicryl. Where do you use, doctor? Vicryl? Doctor got it. It's absorbable, doctor. It is subcutaneous tissue. It is deeper tissue. It is strong tensile strength. Beautiful. Big hand, please. Harshini, Dr. Harshini. Can you take the cat cut? Meow. Good. Can you tell something about this? Yes, absorbable natural suture. Yes. 4O. What is 4O, doctor?
The type of the needle.
Is it the type of needle or thickness of the...
Thickness.
Oh, she got it, thickness, meter square. Okay. That we will check again. Okay. The needle size is 16 millimeter, curved, and the length of this thing is 4O is the breadth of it, diameter of the suture material, and it is about 75 centimeter length. Okay. So have you understood something about the suture material? Good. So with that, we'll go to the next slide. We have a variety of suture material. So we have Vicryl. We have here 2O. What we have there is 3O. What is 3OOO? We will find out what later. The next is monocryl. The Vicryl, which has got one single filament, is called monocryl. That means to say Vicryl can be multi-filamental, right? Then you have PDS. I'm not really sure what is PDS. I just put it up. Can someone check in this thing? Poly-di, some name is there. Okay, PDS. It is actually absorbable. This is absorbable suture. End of the day, it has to be sheep or sheep gut or collagen of the sheep. It's just the name changes, PDS. Alright, come. What is this? PDS suture. Doctor, can you read up loudly?
PDS is a synthetic absorbable monofilament suture.
Okay, stop. Synthetic. Here it is synthetic. But it is absorbable. So all what we thought is cat cut, right? But it is synthetic. So that is the difference here, PDS. What is the name?
Polydioxagon.
Yeah, I couldn't get the name, that's why I couldn't tell you. So it's polydioxagon, it's a synthetic. Okay, next.
Monofilament suture.
Yeah, this is mono single filament. You see how we assess this material? Right, monofilament. Inder will remember that for life. Right? Next.
Made from a polymer of paradioxagon.
Okay, it's a polymer, it's a synthetic material. More plastic type, but it is absorbable. Right, I think that's good enough. Thank you so much. Now, other varieties we are seeing here is Maxon, Dexon, almost same. Alright, they're almost same, all synthetic. Then chromic catgut is the catgut which I told you. Okay, chromic is the one which is treated catgut. But what we have is a natural catgut. That's the different, Alex, Dr. Alex. Then non-absorbable suture, we have silk, Prolene that we use for deeper skin structures, deeper tissues. And then we have Novafil, Supramide. Just you can check it out in your internet. I mean in your this thing online. What are the material made up of? Mercilin and ethylene. We don't use many of these things. However, in GP practice we use nylon. Sometimes we use What do you have here? Vicryl. Chromic catgut, I don't use. Silk, I never use. Because there's a reaction, a lot of reaction. So we stick on to Vicryl and these two things. Even chromic catgut, we stop buying, right? Next slide. Okay, so we proceed. Suture and needles. Now here we have suture and needle sizes. So now you see O. The diameter is 0.35 to 0.39. And then it is usually, O means what? Huge enough, thick enough, has to be very strong, right? We don't use it in our clinic, but it is usually used for fascia and also abdominal wall. All right? In spite of using this, there can be dehiscence of the wound. When you have intra-abdominal things, kind of bloating kind of a thing, you can even rupture that. I had patient, I still have a patient who developed peritoneal, abdominal hernia, right? The next material is 3O. You can see the diameter for your comparison. 3O, usually what we use for, stronger one also, but we use muscles and all the subcutaneous tissue, right? Muscle. Okay, if we are talking about size, size, remember that. The 4O is for the scalp, trunk, and the extremities, the hand, finger, and all. So we have 4O in the clinic, we use that. That's why we stick on to the 4O, 5O, right? Okay, good. Then we have 5O, general skin closure for the limbs, body part, everywhere. 6O is very fine. Ideally, you have a microscope, the scope, right? Then that is about facial and hand, skin, eyelid, going into microsurgical procedure. Then you have 7O, microvascular, tiny blood vessels you repair with 7O. And nerve repair as well, 7O, okay? We don't use 1O and giant into nerve, okay? Then we have 9O, smaller, tiny, you can't even see with the hand, with the eyes. You have to use the scope, then giant, the tiny needle, right? And then you do it for the ophthalmic arteries, microsurgeries. 9O, right? Okay. Now, monofilament, single strand, low friction, okay? Minimal tissue trauma, lower infection. Single filament, low friction, easy, but then easy to run away, okay? Dehiscence. Slip through. Multi-filament. See the filament there? Multi-strand, ease of handling, higher infection risk. Why higher infection risk? Multi. Everywhere the bacteria can stay there. It's like that. Single strand, bacteria cannot. Here, we can do a housing for them. We can even construct histana for them. Okay, so material, we have natural, which is silk. Avoid silk possible because reactive. Then you have catgut, right? Catgut and silk, you've got higher tissue inflammation, right? Higher reactivity. Then you have synthetic, which is nylon, lower reactivity. Yes, next. Okay, types of needle. Okay, these are a bit technical. That's why, interaction is a bit difficult, right? This is a bit knowledge. Boring, to hear from me, right or not? So in that case, I think Dr. Bawani can talk about the slide. Little bit this slide.
Based on the slide, what I understand is there are different type of needles which works for different type of indication. No. So the type of needles which I can see is a taper point, blunt, conventional, and reverse cutting.
Okay.
So on taper point, I think the tip is quite pointy and the body is thick. Is it?
Yep. That's why, doctor, I caught you at point. Like I caught you, right? Okay. Now, give a big hand. If you are prepared, maybe I would be, stumbles. Okay, anyway. Doctor, thank you so much. The next slide is yours again. Okay, relax. Just to create some. All are lepaking, relax, tired. Dr. Alex is so tired. Cheer up. That's the reason, okay? So be prepared. I will be called in. Okay, thank you. Now you see, doctor, taper point. The point is taper, usual, normal, like your suture material that you use for suturing the cloth, right? Taper. Fine. What is so taper? We'll have to know. See here, the most important, this is how it looks from the front. And this is the point. This is the point here. Blunt point is blunt like this. Why a blunt? Hey, it's not going to be tough for the doctors to suture. So that means we don't need resistance here. That means it's going to be a very soft organ. That means we might be suturing the liver, kidney, all those stuff. We don't want to injure them. We don't want to cut through them. Right? Then you have something like this. Hey, what is this, doctor? It is a cutty, sharp, used like knife, and also knife from the front. This is called conventional cutting, 3 shaped like that. But the center is pointed. Okay, if I draw, it's like this. Okay, that's nice. You see, conventional cutting is, this is how it is drawn, right? Correct? Right? But if you see this thing, it's going to be straight, and then it is going to, okay, just a moment, like this. But at the side, if you have a look, it's going to be like this. More or less like this, class. So you have the difficult to draw like that. Yeah. Can you imagine that? It is like a rocket. Okay. You know the stealth fighter? Have you seen stealth fighter? The look it has. The side is like that. The side, from here, it is bouquet coming down and then like that, like a stealth fighter jet. Then the front goes further down, joined by the side. Can you figure out? Boleh ya? Tak boleh pun cakap boleh lah. Okay. So that means there are few cutting edges lah. First you cut, the center, then the side, all these things. So it is easy to swipe through harder structures, like skin. Okay. So now here, you see how it looks, almost same. This is the way, and then you see how it looks. This is the one. Ada faham? Can you see the photo? Like 3 segi front. Okay. Next. Here is much more better. Reverse cutting. This is cutting on top, flattening. This is like this. So you are going to cocok dari bawah masuk atas, like this. You see here. You see top of the needle is flat. Here it is reverse cutting. Clear? Any doubt? Okay. Where do you use skin? You use reverse cutting. Okay. Why? Thicker skin, difficult to puncture. Cutting 3 by 8 circle. Anyway, subcutaneous tissue, taper cutting. Because it is fat tissue. You need something pointed. Tendon, reverse cutting. Why? Tendon is so difficult to suture. Tight, hard. Liver, kidney, blunt needle. Eye, spatula needle. We don't have something like that. Eyes. So we don't have the sample here. Alright? Next, Anna. Okay, here. So with that, okay. So, doctor, before that, you have had needles, right? Have you ever come across complications with the needle? Suturing when you do it. Come. What?
During the knot time I realize sometimes my knot is not so tight. I have to tighten bit the knot.
That is what? Needle.
Needle. No, so.
Doctor, when you are skinning your squat, have you found any difficulties? Sometimes, right, resistant. What suture material is that? Micro, okay. Micro, okay. What about Dr. Bala? Right. Straighten.
Because I think the tension of the tissue is more, the needle becomes like straighten. Then I have to use my.
Okay. So mark the point. We are going to sort out that issue today. Right? Next. Similar, 2 people, 3 people. Dr. Praga, 4. Done. 4 people. You want to say anything, Dr. Harish? No. Anything wrong with your technique? No, Vicky, no. She said no. In there, you find something weird. I don't know why I say. Okay, anyway, we'll see that later. Okay, we are going to the module later. All right, good. So today we're going to see hands-on basic suturing instrument. Okay, hands-on means all the instruments lah what we have. All right. Okay. So with that, probably we pair up lah. Pair up again. Okay. So find your place as usual. Pair up. Pair. Opposite lah. Better opposite. Better opposite. Come quickly. Okay. So you're going to be seated there, and I'm going to demonstrate first. All right? Is it okay? So pair up first. All of you stand, don't mind for a while. Quickly. Then you're going to do the same demonstration to your explain the same thing to your participant, your friend, your partner. Okay? Is that all right? Thank you. Come. Okay, turn back here, doctor. All of you turn here. Alright, as usual, I need to wear my glove. I'm just going to explain about the materials so that you get one idea. And some of you are junior here, so you'll get a fantastic idea. Then you proceed to explain the same thing to your doctors. Okay, good. So now we start with a simple equipment here. What we need to know here, most important. When it comes to the surgical thing, this is the vicryl which I said earlier. It is 3O vicryl. Now you know what is O, you know what is it. And then I'm going to open this vicryl. Now we see what is the complication that we, Dr. Bala and all four doctors went through the other day. Bending, okay? Now, this is a vicryl. So the way we open it, sometimes we find, oh tak boleh buka lah doktor. Minta tak payah. Boleh buka, tak ada masalah. Okay, tarik. Alright, now done. Then we turn. Be careful, so it looks beautiful. Purple, right? Purple color, mudah. Okay, good. Now, I'm going to pick it out. Nice, 75 centimeter length. Okay, quite difficult to visualize, but can you see the kind of the shape? What shape is this? Correct. You got reverse cutting, right? If it is the other way cutting, okay, now you see, reverse cutting is the sharp is down here, right? The bottom here is very, very thin. It is like this. When you clock in or when you take a bite, you go in, if you don't use the swiping technique, the bottom won't hold, it bends up. On the other hand, if the broader surface is bottom and the top is sharp, you hold it, you do this way, it stands. Right? You understand? Similar. Paham? Right. It's like this. This is reverse cutting. The bottom is not strong. But on the other hand, if you have, okay, we don't have a flat surface. If you have like this flat, it stands stronger. Right? Now, and then it's quite long. Perfect. 75 more than that. Right? Tensile strength is very strong. Okay? So again, you see the sharp edge. Perfect cutting. Perfect cutting, right? So now, comes to the other instrument that I'm going to show you. Now, we have, what is this, doctor? Tooth forceps. Okay. Tooth forceps is meant for tissue, it's called tissue forceps. This forceps is important. Why we don't use the flat forceps? Fantastic. Sleep. Cannot bite. The grip, okay? It was a normal forceps. Can't really put it out. Then, there you go. Give a big hand for her. Tissue holding is important. You have to grip it nicely, hold it so that you don't. One part is good, but this is fine. But another thing, if we happen to use the flat forceps, normal one, we are going to squeeze and we are going to crush the blood vessels. Crush the blood vessels. So the technique of holding is like this. This is the broader edge. They give a broader area. Hold it nicely. Hold the skin, whichever way, but don't cover yourself like that. So open up the field. Then you're going to hold the skin like this. Okay, that's number one. Number two, second instrument. This instrument is none other but, what is this, doctor? The artery forceps. What is the purpose of this artery forceps in our medical field? Got it right, doctor. Again, a big hand for her. To clamp the blood vessel, bleeding vessel. These are good things, huh? So anytime you find any bleeding spots, you just go and clamp that area, right? And you get secure. What do you call that? As hemostasis, okay? If it's a spurting vessel in particular, but the one which is pouring also we use the same thing, right? So if it's spurting up to the ceiling, have anyone seen spurting up to the skin? You come to our clinic in the Telokong. Huh? Until kena assistant one part, but you can see dots over there. That means sometimes it goes up. It's not easy, yeah. Even clinic level, we have things going up, right? So fine. So, but that's not the right way, lah. That means we made some mistake, right? So ideally, when you open the wound, careful, lah. Step away, mate. Look for any sputters, right? Then go slowly and can, it all depends also on your assistant. The assistant is good in, covering for you, your body protected, right? Otherwise, our coat may be drenched with blood. So that's another thing we are fearful. So that is why we need this kind of a thing to hold the blood vessel, to bind the bleeding point, and to tie knot to secure the bleeding. Right, that's number one. So we got two instruments there. The third instrument is our needle holder. Okay, good. Doctor, show me how do you hold the needle. Needle holder. Quickly. Perfect. Give a big hand. But I don't accept that. Good. But it is good. It's her comfort zone. Sometimes we look into comfort zone. Not the technique that's being shown in the book. But ideally, if you can practice a little bit of comfort, little bit of technique, put your finger here. Why this finger is over here? Stabilize, right? Have you seen people having the kind of a tremor? Right? If you put like that, even the tremor goes down. So that's number one. So now, joining these two instruments, being held like this, supported here at this level. You see here, supported here. Not like this, huh? Right? This is not the right way. You have to support the instrument here, so you get it. Now you have this on top. So you're going to take a bite, get a nice swipe under the beautiful feel, open feel, not closed, and that's how you use the bite. Most important thing after this, where exactly are you going to take the bite? Can you tell me, Doc? Who is going to volunteer? This is a small needle, no doubt, but it is anterior to 1/3, middle 1/3, posterior 1/3. Where exactly? Dr. Bala, give a big hand. I owe you some treat. Yes, middle 1/3. Done. Can you all see that? Okay, this is the way to go about. Why it's middle 1/3? Huh? The reason? If you want, you can try after this. You try to take a front 1/3. When you take a bite of front 1/3, you can't even get the skin. If you take the back 1/3, what happens? There you go, all for your mistake by the mistake. Now you understand, Bala?
The trial and error, I learned that you should go in the
Yes, okay. So all four of them made a mistake.
I go to posterior.
Best thing is you people treat me, lah. Okay. After this, middle 1/3. Middle 1/3 is the right way, and then don't go and push it just straight. It's not pushing. It is swiping. It is taking a curve. Not swipe, not pushing in. When you push it, it will become. Careful on that. Okay. So I've demonstrated this part. Beyond that, we have scalpel, which we don't use here, right? Sometimes we use for sutures. Before suturing, what is that? Ragged skin, take one cut, make it straight, regularize, make it normal, suture back. We can use that. The fourth one, most important, if you don't have, is your scissors. How do you hold the scissors? You are my assistant doctor. How do you hold the scissors? Wow. That's great. How is it, doctor? Beautiful. Give it to Dr. Harshini. Dr. Ashini, you learned from Dr. Praga, right? Oh, Dr. Praga, salah. Dia cakap. Okay, how is Harshini's style? She's a houseman, Okay. How is it, doctor? They are smarter than us, doctor. We are old timer. Okay. Come. Dr. Ashini, great. Big hand for her. Every time we hold instrument, you are so expert. That's the problem. We always we go there tuck because we are so good at it, right? So, but rightfully, they are the student. They are the new doctors, new generation. We have to accept similar way. But doctor, what you didn't do is you never placed the support system. Okay, Dr. Alex, where do you give the support system, please? Okay, that's one support. Yes. Now you're going to cut the tissue. How do you approach? How many of you accept? Dr. Bala, you are the assistant. The problem is never assistant. Always we are the boss, right? Okay. Yes, Dr. Bala. Okay, depends on the suture material. Good. Nice. Dr. Bala did another extra thing there. What he said is like this. But most okay. Again, but Dr. Bala said, I need to put one support on the top, second support on the bottom. You are right, Dr. Bala. But we just have to modify, bring it closer. Why? You see, very intricate, It's a precision medicine. Right? It is not like go in and no, every aspect, millimeter counts. Why? Doctor, why lah, doctor? You cutting, how you going to cut? What's the reason? You see, cutting is only a tip of it, not here. Right? When you approach an instrument, this is the liver, right? Doctor asks you don't have a support, you can cut anything else. So, but when you put it here, you are still pointing it. Somebody push you back, you want to penetrate, pump. Liver's gone. So when you put it like this, you go, open up a bit, little bit, and then tuck. That's how it goes. Understand? Okay, so I hope I've given you some tips on that. Right? So now, thank you. And this is, I think, last instrument for me. What is this? This is a syringe, and this is the lignocaine. Okay, that's you. So today it's going to be lignocaine. So lignocaine is today. So not water for injection. Anyway, so right, we have this. So what we do, again, when we do it ourselves, we are going to contaminate the hand. Ideally, the assistant will have to come, open it up for us, show it like this. So we take the sterile needle, puncture, withdraw, with two hands like this. Like that. Okay, so you have done all of you done that. So we are going to do that today, and I want you to demonstrate to your partner, okay? And you can proceed now, okay, without any delay, okay? Right, thank you. Go back to your place. Please go back to your place and demonstrate all the instrument one by one, maybe one after the other. Once you finish this batch, once you finish the other batch, okay? Thank you. Okay. Friends, we are going to see this number one batch. Okay, who's going to demonstrate the instrument? Okay. Right. You're not going to suture. You're just going to show, explain what are these instruments again. Right. Just and how you hold the needle, how you hold the suture material, all those things, what I explained earlier. But I want Praga to become expert in that. All right? Boleh? Thank you. Thank you, Doctor. Teaching a junior is excellent job. Okay? Take your time. And then please expect her to explain you again. Right? Okay, good. Okay. Right. Okay. One reminder, once the junior, okay, like Dr. Alex is explaining to Praga, you have to give a feedback to the crowd, to me, to us. This is what Dr. Alex explained. Then you proceed. Same to you. Give a feedback of your understanding about what he says. Okay, fine. Same. Okay. Nanti bagi minuman makanan untuk Arishan. Ya, suruh dia makan dulu. Don't suture, it's okay. Instrument only lah. Okay, instrument only. Later. You're pushing it lah. Third module. Just explain how to demo. Okay. Saya ikut masa ni. Jangan ikut timing tu sekarang. Kita nak ikut timing ini. Tadi kita break dan ikut ni saja. Tapi masih pastikan dalam ikut. Jangan bagi siap. Saya tahu tapi timing. Can I give you another 2 minutes to finish? Right. Okay. Setiap 5 minit. I hope all are complete. Wow, super interaction going on. Good, good, good. Excellent, great, great, great. I'm going to ask you a lot of questions after this. Be prepared. Okay, 5, 4, 3, 2, 1, 0. Wow, good. So nice, so impressed. Okay, I'm going to ask you too many questions. Be prepared. Okay, so shall we be seated? Shall we be seated? Thank you. I hope you have learned beyond what was explained earlier, right, from all our senior colleagues. Excellent. Give a big hand to everyone first before we start. Now, let's start with Dr. Praga. Dr. Praga, what new information that you got from Dr. Alex?
Dr. Alex give me usually during the suturing time I will use one set of glove after I done all the suturing, and before I did the dressing, bandaging, I will remove my glove and then I use another set. But Dr. Alex advised me, Dr. Alex gave me another idea to use 2 set of glove at a time. So once I use the first one, I remove it, and then can use the second one.
Fantastic. That's a beautiful innovation.
So usually at OT they will use set of glove
Correct.
at a time.
Yes, excellent. Thank you, Dr. Alex. Because OT they use double glove,
Yeah, double glove.
right? And OT they use double glove to prevent us from getting pricked. More extra protection.
Yeah.
This can be applied, yes, in our GP practice in case you are going to use
2 set.
2. Okay, but if you have a fantastic assistant, you may not have to,
Yeah.
right? Okay, good. Always good to wear double glove
Double.
for better protection. Good. Thank you so much. Give a big hand for Praga. Passing over to Dr. Alex. What is the new stuff that you learned from Dr. Praga?
Even though we don't use in GP practice the instrument, but she told right after you, because the other day you taught her
Ah.
that, about autoclave.
Okay,
You have to use 121 degrees heat, and then for 15 minutes
Right.
you sterilize water.
right. And 15 to 20 minutes of time.
Time.
Okay, this is about extra thing that I asked Dr. Praga the other day.
Yeah.
What is autoclave? What is the temperature? Because that's what we learned in our second year microbiology. Second year, right? Now I'm going to ask you, doctor, what is the temperature and all this thing in autoclave? What temperature do we use?
Not really sure.
Fine, good, fantastic. This is the answer that the medical student should have. Not sure, it's not sure. When we go around and taking a corner and all this thing, hit around the bush, yeah, good, thank you. But remember this, very important. Autoclave is an instrument used for sterilization of equipments. Although we don't have it in our clinic, we use hot air oven, the temperature of which is 160 degrees Celsius, and also 15 to 20 minutes. Here, autoclave is used in the OT. prior to operation. So there they use 121 degrees Celsius, the temperature. They use it for about pressure exerted is about 15 minutes, around that, 10 to 15 minutes. And they use timing is about 15 to 20 minutes. So they have pressure and also time. And this has to be followed properly. If you don't follow the protocol, your instruments will get not sterilized. Right? So that's important thing. Okay. Apart from that, any other sterilization method that we can safely accept in the clinical practice?
We can soak it in chlorhexidine.
Chlorhexidine. Give a big hand because that's a very old method, yet it works, right? But it is not accepted, okay. So, but you know why? It's a good, cheaper. But another thing is the instrument get rusted. All right, Dr. Bala, with your experience, I know very well. What 2 equipments you want for sterilization? 2. I give you 2. Along with? Yes, good. Fine, you got it right. 160 degrees Celsius, 15 to 20 minutes, hot air oven, 100% sterilization, transfer to ultra wave. What wave is that? Ultraviolet. Keep it there. Perfect sterilization. Okay, you don't have to buy autoclave, which costs you about how many thousand? Just 20,000 ringgit. Okay, so too expensive. Huh? The budget goes so high, right? Okay, now next. You will learn something. Mr. Inda, our medical student from University Malaya. What you have learned? New stuff from Dr. Bala.
So Dr. Bala taught me again the way you hold it.
Okay.
How to grip a needle,
right,
using the needle holder.
Right.
And then the ways, and also the one tough thing is of course the scalpel.
Wow.
Yeah, inserting the blade towards the scalpel.
All right,
Yeah,
good. Thank you, Dr. Bala. Okay, innovative. That's very good. Something extra that you learned. So I'm happy that Git taught you about how to insert the scalpel. Excellent.
Yes.
Thank you so much. Yes, Dr. Harini, Ashini. What is the new thing? Oh, Dr. Ashini today want to be very vocal. Brani sudah keluar leh. Okay, good. Fantastic. So happy, give a big hand lah. So timid, so quiet. Today she want mic to speak a few points. Fight for your right, doctor. Okay, good. Go ahead.
So Dr. Bawani taught me how to first open the needle, the packet of it.
Right.
If let's say you don't have an assistant, you can actually just like open the packet and then drop it after you drip and everything.
Right.
And then after you are gloved and everything, then how you open and then you grip the needle using the needle holder, and then the lignocaine they prefer to use the green needle actually. For if let's say fine structure like the face, the nose, then it's an orange needle. We
Right.
have to aspirate first.
Right.
And also the side effects, if let's say we give too much lignocaine, the patient can have the numbness, and then they can also have seizures, and then how doctor actually like demonstrated
Right.
the
Good.
stitch.
Give a big hand. You know why? Dr. Bawani has been challenging me from the time she came in. Right? She gives so much of point which I never mentioned. Give a big hand for her. She went into cosmetic surgery today. Beautiful. Thank you. Right. Now, we have done all within our possibilities. Let's see the facts here. Right? Hands on. Correct handling. Have we did that? Did we do that? Correct handling of tissue forceps. What about scissors? Perfectly done. Big hand again. Next slide. Next. Now, where's the bite? Almost, not the top, not the tip, it's almost in the center. Are we right? We are right. Next slide. One thing that we never mentioned here. What is that? Laughter from the other side. What is that? That part is not utilized, not mentioned. You already opened the suture, nice play with the needle, then disposal is not done, doctors. Salah kan? Oh, it's a procedure only lah. Okay, tak apa, terima. So next, what shall we do? Okay, we are supposed to be taking break 10 minutes. We are there about 10 minutes now, right? So I would like to call as a mode of motivation for our juniors here, right? I just want to know, up to now, what have you learned? Inder, go ahead.
So obviously we've learned how to describe a wound and all from module 1 earlier.
Yeah.
And of course, how do we irrigate it, and moving on to module 2, where we're learning the types of suture that we use, absorbable, non-absorbable, and of course we're learning the instrument, the types of instrument, the way we handle the instrument, and the aseptic technique that goes with it as well. It's important, and I think the way we use, mainly the way we load the needle, the positioning, the misconceptions that people have on where to hold the needle and bite the needle, right? Yeah.
Do you think you've learned anything more or beyond what you have learned before this?
Yes, of course. With experience around me, I feel I've learned a lot of things today.
Fantastic. You are third year in University Malaya.
Yes, doctor.
Good. But anyway, the hospital will expose you.
Yes.
The most important thing is we have to pursue.
Yes.
We have to find it.
Yes, doctor.
All these things you have to go back, practice it. Okay. Later on, after in the 4th module, you will be knowing how to do the knot. Right? Today will make you perfect in suturing. That's the aim. Our guys here, our doctors here are all experts. Right? There's nothing new, but they're also learning. Doctor, anything new that you learn, doctor? A lot, right? Brushing up, right? The holding technique. It's all new for me as well. So this is brushing up. The method is simple. We keep on doing things like this. We improvise, we become perfect. That's the reason, okay? Dr. Harshini, you are going to go into a hospital, right? That is Hospital Tengku Ampuan Besar Rahim Aklan. You are posted in a department, surgical department, and there's one bad doctor by the name Dr. Kiran, who's going to come and instruct you to do suturing, right? Now, this is the wound. I'm going to ask you, okay, wound here lah, okay, right? Dr. Harshini, what type of wound is this?
Morning, sir.
Stop saying morning, sir.
Good morning, doctor.
Yeah, morning, doctor. Good morning, morning, doctor.
Morning.
Confident, yes, good. Stand up, Dr. Harshini. We bring you power today. Okay, come, sit down. Stand. Yes, Dr. Harshini, what wound is this?
Doctor, I'll inspect the wound first.
Yeah.
So after
Stop again. I will inspect, no.
I inspect the wound.
Based on my inspection.
Based on my inspection.
Don't say will, because you've seen the case earlier, right?
Yes, doctor.
Tell me, yeah.
Based on the inspection of the wound, this is a wound on a 50-year-old gentleman. It is based on the.
I don't have time lah.
Oh.
Cepat lah, apa ni? Quick.
Forearm, single wound. It
Okay.
is about 5 to 2 cm with a depth of 0.5 cm.
Okay. So what do you think want to do? Suture.
Clean the wound, irrigate,
Ah.
and then after, if it's a ragged edges, we have to give the incision, and then
Okay.
after, take consent, and then
Good.
suture.
You're done well. Big hand, please. Now you're going to see how the senior does it. Come. Dr. Bhavani, this is your wound. Right? The MO now. MO. Okay. Bhavani, how are you okay?
Yeah, fine.
Ini pakai segak sikit ah. Apa? Buat apa tu? What do you see today?
It's a deep cut wound.
Finish. Deep cut wound. Some more. Mantap lah. So,
Okay, so I'm going to proceed with toilet and suturing.
right, okay, good. Okay, so, right. I don't have anything to talk here, I'm going to proceed for toilet and suturing. Okay. So, hemodynamic, how is it?
Oh, vital signs are stable.
Oh, any problem, other problems?
No,
Diabetes, nothing, huh?
no, glycemic control is good.
Fantastic. Okay, so, put a usual antibiotic lah.
Okay.
3 days lah. 3 days okay ah?
I should be fine.
Okay, good. Thank you. That's it. You see that? So the difference is Houseman, MO. Now I'm going to see the specialist. But can you see? I don't want people to be quietly sitting here. It's just yoga. Okay. Thank you so much. And now what's the time? Okay, time's up. We just completed successfully our second module, and we have about 15 minutes of break. Give a bigger applause now. Not easy, standing here for 2 hours and you sitting here for 2 hours on Sunday. Thank you so much. Let's take a break. Okay? Thank you. You feel nice. You feel nice, right? Am I looking okay or not? Ashwini, double. Ashwini lebih lah sudah lah dia. So rosa lah dia. Okay. So recording ah. Okay. So for this third module, okay, it's almost the same, but we are going to advance a little bit further. Okay. So we are going to start with a simple slide presentation, followed by some video visualization. Okay. We're going to observe video. We're going to see some expert playing some trick there on suturing techniques. Okay. Now, module 3 is basic suturing technique and learning outcome. What is the learning outcome here? How do you apply sutures? That's number 1. Correct tissue handling, whether you handle the tissue properly or not, which you already mentioned earlier. Then common suturing error. Okay, with that, can I have next slide? Okay, now doctor, we are going to go through fast. Okay, so we have only 20 minutes, we'll finish it off. Gentle handling, minimize tension when you're holding the skin, or you're going to approximate the suture. Never tie it too hard. Earlier we saw some picture where you find the tensed up suturing. Sector is ensure precision. That means how do you arrange one suture after the other? What is the distance that you're going to have? Alright? What is the distance between the bites that you're going to take? Right? Then irrigate, clean the wound, followed by, of course, you have to avoid crushing tissue. Don't strangulate the tissue, important. Make precision, irrigate and clean the wound. Any doubts here? This is only slide, so there's no doubt. It's straightforward. Next. Next. Okay, suturing technique. This is important. This is important. We have come across plenty of sutures, plenty of techniques being employed depending upon the tissue or the organ engaged. Now here, we are going to explore 3 important suturing techniques. Number 1 is continuous suture. Number 2 is simple interrupted suture. Simple, word, mind the word, simple, but it's interrupted. Okay? And then is mattress suture. What is simple suture? When do you apply simple suture? Anyone wants to give a point, give answer. Where do you apply simple continuous suture? Perfect. Clean lacerated wound. But again, there's a little bit of issue here. Let's say someone gets into trouble, they cut their skin, come after about 2 hours to our clinic. Do you go for simple interrupted suture? Person get into trouble, cut laceration, come to the clinic after 2 hours. Do we go for continuous suture? What suturing we would prefer? Why? Come doctor, take your mind.
Simple interrupted suture.
Simple interrupted. Reason being?
Because the continuous, if one suture is included, means everything can be open.
So why you want to try to, why you are avoiding continuous? Dr. Bala just mentioned that clean cut, laceration, I would go for this one. Why in a 2 hours time, it's a clean cut, laceration, straight suture, straight injury, right? Clean cut. Why should we not to go for continuous suture?
If it is a high tension area, it's better interruption.
Okay, doctor says if it's a high tension area, it is better to go for interrupted suture. Any other ideas? Pass the mic, please. Thank you. Thank you for your answer, Dr. Praga. Yeah. Okay, next same answer. Next passover.
Because the timing, it's been more than 2 hours.
Okay, something there, timing, doctor. Right.
Contamination.
Yeah, Dr. Bala got it right. Big hand, please. Yes, any wound until the doctor cuts it, like lump excision, we cut it. The field is clean. We go for continuous suture. Operative skin, operation in the OT in the hospital, they cut the abdomen, they can go for suture, continuous suture. But when the person is injured by some other mechanism, glass cut, knife cut, whatever cut it could be, okay, we don't go for continuous suture, right? Now, dog bite, Dr. Alex, dog bite, right? Nicely chewed, but looks okay lah, like laceration. What would you prefer?
No suture TNS done for dog bite, any bite injury because of the secondary infection.
Yes. So doctor says infection, no suturing. So what you would do?
So we can irrigate and dressing and monitor the patient.
Wow, that's good. Irrigate, monitor the patient.
And
That's all, doctor.
antibiotics.
Antibiotic. What antibiotic, doctor?
Broad spectrum, augmentin.
Broad spectrum. Give a big hand. Augmentin. Any IV antibiotic, doctor?
Yeah, IV Rosapin.
Rosifin. How many days, doctor?
Depends on how bad and how contaminated the
Right.
wound is.
Okay. Depends on how bad. Roughly how many days, doctor?
3 days.
3 to 5 days. Big hand, please. So now we know bite wound cannot be sutured. It should be exposed. You can pack it with povidone, fine, but you have to observe every day. Look for vital signs, hemodynamic stability, temperature, pulse rate. The next day, all these things are very important. When it comes to the issue of rabies injection, immunoglobulin, have you learned about that vaccine? Dog bite. Do you give immunoglobulin for the patient? Why, doctor? Take the mic, doctor.
Usually if we see if any tissue involvement or vascular involvement, then we might suggest.
Okay, doctor says vascular involvement, deeper cut, or we give immunoglobulin. Is that true?
And also based on the history, whether a dog exhibit any symptoms or
Or you're going to search for the dog?
no, but based on the
Okay, more accurate. You are right. You are right. I'm not going to say anything. Perfect. More accurate answer. It's a notif. Doctor says notifiable disease. Give a big hand. Yes. But I have got my dog, Dr. Bala. He comes and chew your skin. You're going to notify him. Dr. Kiran's dog bit my leg. That's a question to answer, right? So when do you give immunoglobulin? That's the question here. Endemic area. If the area is endemic with scabies, then you can proceed, inform, notify, and give. Yes. If it's not endemic, no need. Telogong endemic? Klang endemic? Where is endemic part of Malaysia with rabies? Sarawak. Big hand, please. Anywhere else in Semenanjung? Kelantan and Terengganu side, border with Thailand. Okay? Boleh ya? I remember once I saw a case, just a little bit. This case exhibited, you know that heel to hip, what do you call the spasm? What do you call the one? There's a name for that. Tetanus what? Not tetanus. No, tetanus. That is scabies, right? There's another case, tetanus problem. What do you call the one? Heel to some spasm lah. We'll refer back. The patient exhibited that directly, and we were the student appearing for the exam. Right? Arch. The moment I saw that, doctor, is this tetanus? Hey, you gila? This is what they asked me. You gila? Where got Malaysia? Where got tetanus? And that was a neurosurgeon actually. Top neurosurgeon. I said, no, doctor, the patient is exhibiting this particular sign. Oh, you think you're from India? Oh, everything is from India, is it? Laughing, everyone laughed. Patient died, day 15. Diagnosis, tetanus spasm. I'm not saying I'm not smart. No, definitely not. But we have seen enough cases in India. Right? Right, doctor? We have got tetanus bed Rabies bed, right? Separate, right? So sometimes don't assume. That's what I'm telling you. Even Telok, if you find the symptom, shoot straight. No harm in diagnosing wrongly and proceeding with notification or informing the government, hospitals. Then just keep quiet, no lah. Right? Be careful, be careful. That's the thing. Coming to the suturing technique. Simple suture, you know how they do it? Continuous. Take a bite, another bite, synchronize. Swiping and taking. With the same needle. There's no gap. Simple interrupt the suture. Take a bite, put a knot, cut it. Take a bite, put a knot, cut it. Maintain the distance, both the distance. Mattress suture is a rapid closure, high tension wound, abdomen can pop out. Then you go for, there are two types. One is horizontal mattress. The other one is vertical mattress. How many of you have done vertical mattress? Horizontal mattress? Maybe I can demonstrate that later. Okay, next slide. Improper knot, common error. Knot is not secured, excessive tension, right, doctor, you mentioned earlier? Necrosis it leads to. Then poor skin edge approximation. I'm going to say how you're going to approximate later, okay? So eversion, go up and then open up like that. Opening up the whole wound, okay? Eversion. Excessive tissue handling. You go and keep on biting everywhere. You crush the blood vessels, it's going to go into trouble. Wrong suture material and size. You go and take O to giant face. Or you take 9O and giant kaki. Example lah, we don't do that mistake, right? Anyway, so next. Now, let me stop first, let me breathe in, okay? We'll dim the place, make it more romantic today, and see the white man doing his job. Can we, all together? We can even stop the video in between, you can ask questions. Can we do that? It's about 10 minutes, I might even stop it much earlier, but let us see what's the time now, okay? Thank you so much for your attendance. Look into the video. Thank you. This is a normal one, what Dr. Praga saw the earlier day, where there was spurting of blood. She tried to squeeze. Now you see here.
You can see goes through epidermis and dermis, a little bit of the fat, but it doesn't go into the muscle layers. There should be a big tendon here that makes your thumb go up and down, and we don't see it.
So, do we have to dim the light? No need, huh? Just nice. Okay, good.
So we know there's no involvement of tendon. So essentially, it's a simple, kind of a little deep, nice linear laceration. She's already been numb, lidocaine 1%, so feel pretty numb.
Okay, can you go back earlier? Start back from the beginning with the sound. Okay, go back. It's not too long, I think. So we can afford to. Sound maximum. Alright, this is a cut over the hand. That's the thumb, base of the thumb. See what is being done. The evaluation of the skin is totally different, okay?
So you can move the thumb up and down, sensation. Of course, we know just that might have gone away a little bit. And then you look to see how deep it is. So in this one, we clean up real good. And this one, you can see goes through epidermis and dermis, a little bit of the fat tissue, but it doesn't go into the muscle layers. There should be a big tendon here that makes your thumb go up and down, and we don't see it there. And when we move it, we don't see a white thing moving up and down. So we know there's no involvement of tendon. So essentially, it's a simple, kind of a little deep, nice linear laceration. She's already been numb, lidocaine 1%, so feel pretty numb. You let me know if it's not or whatever. Possible if you want to use absorbables, that way the patient doesn't have to get them out. If that doesn't work because it's a very tense out area, like this is going to be moving and pulling on it, you want to use something strong that's not going to break, because dissolvable spaces will start dissolving and then they'll break too quick. Give me all this organ. Oh, there it is. All this organized interruptions. That's part of the ear. That's sometimes it's fun and sometimes it's like, gosh, give me a break. Alright, so we've decided to use Prolin. This is basically a fish line. and it has a lot of tensile strength, and we're going to do a running stitch so that way we don't have to do each individual suture and we can get done a lot quicker. And it looks real pretty when you're done. The most important thing of suturing is that you go perpendicular to the seam like so, and you grab a nice big chunk. You want to not be too close to the edge, and you want you to go all the way through and out.
You see, we are not using any forceps there.
Distance
Instead, they just take a bite.
perpendicular.
That's
in,
one way, huh?
perpendicular out. Now this anchor stitch, this is the first one you do. It's very important you get it right because if this one breaks, all the other stitches will break later. So you do what is called a square knot. You tie forward once, backward once, forward once, backward once. You do that 6 or 7 times to make sure it's nice and tight, it's not going to break through. Now, one thing you should learn in medical school and PA school, nursing, whatever, is you approximately, you don't strangle it. You don't pull the tissue together so tight that this is like in there, because that creates what is called vascular necrosis. If the tissue is too tight, circulation bad, and then you can actually increase the chance of infection, or the tissue kind of dying, getting necrotic. So approximate, don't strangulate. And then we could do either as a continuous, but I like to do as the continuous interlocking, and you'll see. So when I go in, perpendicular in.
So this is a continuous suture
I go through the loop.
with interlocking. Okay, you can see the interlocking part.
Essentially, they'll make it look like a baseball switch.
You see that?
I just love the look of it.
This is continuous with interlocking. There's also continuous without interlocking.
And I like that whenever possible, I ask the nurses to bring me the biggest needle of the size I want. You want small ones where you're doing face and very, something where it's very particular, the cosmetic result. But you don't have to go in, out, you want to do one sweep. Especially if they give you one of the biggest needle you have as you go through. Again, in perpendicular. Seems like these needles are a little not so sharp.
So with continuous interlocking, you can see in between the sutures, there's one line over there, the suture line, right? Holding it apart.
I think when the doctors do interrupt a stitch or something like this, they're doing laceration repair or something like this for half an hour or more. You know, in the ER, you also have to be quick. You have to be able to. I got a lady waiting for me for a few huge abscess drainage. So I don't want to get home. I'm all done and I'm not going to get done on time. It's 10:11. Done at 11. No way I'm going home on time. But that happens. That's what emergency room nurse. Can't schedule everything.
So normally we do continuous interrupted suture, but if you find your assistant in the clinic not so efficient, may fumble, so you can employ this type of suturing. So you just have to cut in the beginning and the end using your own skill of cutting, using scissors. Right? Look, approximation is quite good. It's fine. Holding is good, not under tension. The wound edges are well approximated. Right? Edges are important. Okay? No undue tension is important.
Call it a name. Yeah, I'm gonna pull that last one. So the last one, you don't pull it all the way through because you're gonna grab the whole loop and then pull it through.
That's the last
grab
knot.
it again.
Secure it properly
And start
again.
going back and forward around the forceps. Back and forward. You alternate, so you're throwing like a square knot on top of each other. Square knot after each other. And you're doing enough that this thing's not gonna get loose in a few days. And people ask all the time, how many did you do? Anyway. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. She could have used one more right here.
So berapa ringgit 14 kali berapa ringgit How much do you charge doctor in your clinic? 15 ringgit, kesian. Okay, baru punya klinik kan? Okay. Dr. Alex? Same I think it's time to increase lah. So much offer, right? Okay. 150, okay. How much are we charging di sana? 20, kita sudah naikkan. Nak naikkan ke tidak? In KL, each suture costs you 70 to 80 ringgit. Right? 70 to 80. But we can't do that in Klang. So let us have some decent thing, but 20, 25 ringgit should be alright. Because we are not taking into account of the lignocaine or lidocaine that we use, the dressing part. If you do it systematically like this, you can impress the patient. Well, I went to the clinic, saw Dr. Alex. Dr. Alex covered it properly. And then he did pakai mask, cap semua dia pakai. Dia buat macam ini. 30 ringgit saja. Right? Now, go back. Serious now. Did you see the video? Okay. What did you see? Suturing. What is the type of suturing? Continuous suture. Correct. Give a big hand. Continuous interlocking suture. Alright? More than that, there's another one called continuous suture. Right? So now, you visualize this slide. I think it's just time for us to go hands-on. But before that, do we have any points to be mentioned here? Dr. Ashini, what did you see just now? Can you comment on that? So Dr. Ashini said same continuous interlocking suture, some more? Yeah, how they precisely? Approximation, give a big hand. Next, doctor.
The way they handle the instrument, the position of the needle holding for the suture.
Right, needle holding is another point. You have to learn this, memorize this, because you're going to do it after this. Some more? That's all, doctor. Good. Dr. Bala.
Space between the sutures.
Yeah, the space, the distance between two sutures has to be synchronized properly. Okay, right, fine. Next.
Observing the wound first, then draping it properly, and also going on with the continuous interrupted suturing.
Fantastic observation.
Yeah, interlocking suturing, and then making sure the proper approximation and also the distance.
Excellent. That's a beautiful way of putting it. The initial phase is evaluation of the wound, evaluation of the tendon, evaluation of the nerve function, bleeding, subcutaneous tissue, muscular layers. All these things are very important. Right? Very good. Big hand, please. So, they're old timers. They thump. Yeah. Okay. Good. So, standard, we all are same. Okay. Now, Dr. Alex, anything else you want to add up? Yes, Dr. Abzor, fantastic. Give a big hand again. You see, minimizing the tissue handling, right? Minimizing the tissue handling, right? The next thing is, if you were to do a bite and then take out the whole thing again, using your hand. Normally we use hand to pick up. Avoid that technique. Use your forceps to take it. That's good. Dr. Praga, anything else you want to add? Hey, enough, Doctor. All of this. Huh? Okay, exposure, contamination, all those things. Anything beyond that you observe? Huh? Yeah. Did you see the first and last knot they gave? Did we ever do that? We do for 3 or 4, right? Okay. This is another method of doing securing. They want to make sure that it doesn't come out. Nevertheless, if you do it properly, one this way, one the other way, one this way, the other way is also safe. Right? This is a bit more exaggerated, right? Okay, fine. But the more, the merrier, the better. Good. So with that in mind, so it's your hands-on mode now. So all of you, right, will be pairing up as usual. All right. One will perform, the other one will assist. Okay. Assist means also where you need a complete attire today. So you have the PPE over there you can wear. You have the sterile glove you can use. You have the mask. You have a cap. With all this thing, you're going to be a surgeon today. Give a big hand for surgeon. Okay, please proceed first. Go. Take your time. Give you about 2-3 minutes. Help each other, please. Where your sterile glove, please. Anything to be full, you have your plastic bag over here, yellow color plastic next to your table. Yeah. Okay, don't do it. All of you are ready? Now find your place. Okay. All right. Video recording going on? Good. So, opposite. Face each other, please. Face each other. Today we have surgeons 6 of us, including me, 7, right, to perform suturing. Please start meticulously from dressing. Mention about irrigation. Use povidone. Use salt. Clean up. Dispose in the plastic bag. Sharp. Give injection. You have lignocaine solution over there on your table. Right? One will hold the bottle. The other one will puncture and draw, instill, and then suture. Maybe the senior can perform. The juniors can follow that later. Both. Then we'll get a feedback. Is that okay? I'm just going to observe, nothing else. Okay? Thank you. And you can talk louder. Maybe Dr. Bala can do a running commentary.
In the inside the wound, I see some foreign body there, right? You have to irrigate the wound. You have to clean until the edges of the wound. See, once we secure the bleeding, we inspect the wound. Palpate the wound, just palpate the wound. If there's any tenderness, pain. No foreign. Oh, okay. We palpate the wound to see any foreign body remain there. Okay. At the same time, we normally see the face of the patient, see for the tenderness, when our hand will be here, but we will be observing the patient's face. Yes. Now use the povidone before we go for stitching. Just povidone. Okay. Yeah. Okay. Yeah. This is where we from the center away, right? Yeah. And we can do it in circular movement. Once we are comfortable, the wound is clean, we can proceed for next suture. So I'll hold the lignocaine, draw out the lignocaine. Which is comfortable. You want to hold that matter.
box ke apa ke berapa barang baru dia present the last person, the last one boleh present gula-gula interrupted. Continuous, not continuous.
Just simple interrupted.
Simple interrupt. Or you want to go to metro suture can, you want to do continuous suture also can. It's open for you, right? Open. But you don't have to follow what is there in the video. Once your son assisted the doctor, use the same model to find other place for you to get the practice. Okay? You don't have to go and feel anything. Okay? Just get the feel of it. Okay? Ikat nafas. Apa ikat nafas? Boleh. இல்ல நானும் வந்து we can take out. So
your partner before healing. Okay, good, good. Slide. Next slide. Next slide.
You see, when you're coming out, you could go. Oh, this is what this is what the is what you do. Second one, taken the bite. You to get a walk inside. What you should do, you don't go inside, right? What do you do? Where to go? You go inside, what happens? You get back, similar, right? See? Keep the body, body. Saw that? Saw that? This is it. That's it. Then you take the same time. Take the same right on. Put it. Yeah. The same thing you want to do, right? Interlock. So that?
Yes.
Okay. Just put it. Yeah. Just put
One bite, jump this side. One bite, jump this side. This is horizontal. This is continuous. What do you call what suture? Interlocking. Interlocking. Continuous interlocking. Suture. சரியா அதான் டாக்டர் சொல்லுங்க விஷயம் இதை வச்சுட்டு எவ்வளோ Last 5 minutes. அதோட next jump throws. Choice. நிமிஷம் கொடுக்கலாமா தேவையில்ல. Attention, experts, surgeons, can I have your attention, please? Okay, I think I've seen enough. Probably enough for you to comment about your work, your colleagues' work. All right. So what we do is we have to go back to our seat. Maybe we can about our suturing. All right. While you can take out your glove and also your cap, you may and also your mask. You can still retain your PPE for a while. Okay. Is it okay for you, or you want to wear it again? Don't dispose it off. Just keep it on your table. Okay. Dr. Bala preferred to be surgeon forever. He doesn't want to take it out. That's good. Okay. Before we proceed, thank you for all your expert suturing. That's what we call suture savvy. The name was coined by our Sifu here, Dr. Tim. All right. So that I've not mentioned. Now, all you've done, are you all satisfied with the suturing? How at ease you were? Comfortable? All right, good. So before we proceed, I would like to call upon you to comment on your partner, how she did the suture. That's very important. I give you 1 minute each. 1 minute each, and give me another 4 minutes to comment about what happened earlier. Okay, give you feedback. Okay, start. Start, Dr. Ashini.
So my partner was Dr. Bawani.
Okay.
We did the simple, the interrupt suture and the continuous suture. So Dr. Bawani taught me how to perform the sutures, and she was very helpful in teaching me how to even do it. So it was perfectly done.
Okay, Dr. Harshini says perfectly taught, Perfectly done. Give a big applause. Okay, before that, Dr. Ashwini, I haven't finished yet.
Yes.
Do you think you have done any mistake there?
Yes, because of with me, yes.
What was it?
Oh, mine was the approximation of it.
Okay, approximation, there was a problem. It's okay because she's just new, it's all right. Anything else? All other perfect. Give a big hand. All else are perfect. That's what she says, right?
I know with Dr. Bawani it was perfect.
Okay.
But with me, I find it a bit difficult to do the continuous.
No worries, because you are new, as I told you. When you get exposed, everything will fall in place. Dr. Bawani, please.
So Dr. Ashwini did very well actually.
Wow, give a big hand again. This is what we need to know, right? Great.
So her instrument handling was perfect. She's able to hold it nicely. The positioning was good. She's left-handed, by the way, so there's a different way of doing it from my way. But the only thing she just need to practice more is on the spacing and approximation.
Okay. What about you, doctor?
I think I should work up more on the same part.
The C doctor should work up more. Well, I don't think so. Okay, they're experts. Okay, good, doctor. Thank you so much. Dr. Mala, comments on your junior? Inder.
Actually, Inder did very well for a third year medical student.
Fantastic. Give a big applause.
For the third year medical student.
Right.
Very ambitious. He straight away went for continuous
interlocking. Oh.
I think we go for a simple thing first. We do the simple interrupted first. We are pro, then we go to the next step.
Wow, that's an opinion from pro. Better accept it. The reason being, simple interrupted suture can suture everything.
Relax.
Right?
Relax.
Okay.
We wear the cap for prevention, right?
What is that? Prevention of?
No, even for this, it was like
No,
that year, done very well for.
Oh, fantastic. That's why. Give him an applause. He's good. He's good. I saw his work. Right, fantastic. If you want to be an expert, you have to take a pillow, take the suture material, keep suturing every now and then. That's it. Easy. Huh? Okay, Inder, what about you? You want to comment on your mentor?
I have nothing to say because he's been a really great mentor for me.
Right. Okay.
Yeah.
Good. Thank you.
Yeah, he guided me throughout the whole way.
All right.
Taught me some new techniques about tying the knot. Yeah, and pulling on to the other side while tying the necks and all. Yeah, and I feel he's a great mentor.
Thank you so
to
much.
start switching.
Wow, that's good. Dr. Alex.
Dr. Prabha did a very good job.
Okay.
Handling the instrument, holding it, and then the cutting, and then the capping also.
Fantastic. Give a big hand, please. Next, Dr. Praga. You comment on Dr. Alex.
Sutures, no?
Hey, Dr. Alex taught you. You have not been doing that? Oh, simple continuous. Fine. Okay, that's okay. All right. Okay.
Otherwise, yeah, the suture just now was.
Okay. All of you are very confident of what you did. Give a big hand, lah. Unfortunately, we have who's the winner here, Okay. That's a part that I want to tell you. Okay, can I declare first the winner? Is it okay? Straight, without any what do you call time. Who thinks that they deserve to win? Put up the hand. No, put up the hand. Put up the hand. Our team deserves to win. Be bold. Who else? No challenger? No challengers? No, huh? Well, what she said is right. The team won. Okay? And for that, we'd like to invite both of you to receive the presentation. Come. Dr. Chin, a simple presentation that you're going to give. Come, sir. Okay. This is, okay. Don't worry. Okay. Dr. Tim, this is what I expect to give. Okay. So the winner for the Suture Savvy today is the team Dr. Bawani and Dr. Ashini. It's an encouragement for you both. Enjoy the sweet, you get diabetes. Switches, I mean. Okay, good. Okay, thank you, sir. Right. Okay. Why am I citing them? Because Dr. You know, that's an appreciation. Okay, very simple. Let me put it straight. There can be flaws in the procedures. There can be technique error. That's all right. You can improvise. But you see the work they have done. They draped the place properly. Look at your table. This particular drape. On top, they covered it well and then only exposed the wound area. That itself brings them the point. Next, although they made a mistake, that was a mistake, Dr. Bhavani. You did the suturing part. You handed over this needle for her to dispose. Same thing what you did. You were given to you, but you injected. Right? That is wrong. You cannot exchange the needles. You have to dispose right away. The injector have to dispose. Here, our doctor kept it here for to be taken for home. Come on lah, Dr. Alex. What pranga? She's sharp, you know. They are very dangerous. This is called safe, sharp disposal. Alright, so that's why I told you guys, beginning itself, you should assume that you are doing a real job. Alright? See, this is what I would like to observe. Okay. Apart from that, Inder, enthusiastic, fantastic, step by step. Right? Always be perfect with the simple stuff. Simple, continuous, simple suture solves 99% of the cases. Right? The rest of the things are just for increase the tensile strength. Now, coming to this suturing, of course, beginner, the alignment is not good, can be improved further. You see the distance between suturing, run. Look at Bala, there's a distance there, okay? And if you look at the suturing part, can I point this? So one is haphazardly, the other one is haphazard. One over here, one over here, one over here, and you have increased the tension here. The one which you saw in the video earlier. So this. Now you see, is there any tension? The gap in between? And the best part Dr. Bala did, which I don't see anywhere here. 1, 2, 3. Here is also not bad, but here is worse. One knot over here, one knot over here, one knot over here. Okay, this is better. Okay, and here, where is it? This is also lari lah. One over here, one over here. See, jumping here, jumping here. Why we need knots to be arranged all at one corner is make it easy for us to STO. Number one. Number two, you can just leave it like this. For instance, you see. This is very important thing that we need to know. Okay, we fail to realize at times. Okay, come. Thank you. You see, this is the wound approximation. We have the wound over here. This is the wound. Okay. All right. Now we suture, puncture. The distance between these two has to be same with this. Better. If you don't maintain a proper distance, what happened to Inder? Tensile, the strength, the tension will increase. Because you take a bigger bite here, you take a smaller bite here, you are pulling down. That's the reason why you get squeezed in. Contracted wound. Okay? So always remember the distance. Same goes for a distance like this. You take the suture here. If you go one over here and one over here, what happens? You squeeze this, you release this. That's the technique. That's why the seniors, you can see they put perfect suture. That's number one. Number two, you take a bite, you go in, you come out. And then this is the suture, you lock it here. Correct? And you follow all over. Same. Lock it here, put a knot here, secure the knot, secure knot, secure knot. Okay. Why it is so important? I ambil satu jalan je. Why? Can anyone tell? Try to relate that the way you cut the remove suture. Correct? So here what we do, when we remove the sutures, if you assume we put the knot here, one knot here, one knot here, what the staff nurses are going to do? They are going to pick this or pick here, tarik, potong sini. Betul? Yes. And then potong sini, dia tarik ni. Apa jadi? This bahagian which is there inside, infected portion will go inside the body. Can you apprehend it? Can you get it? So that's why we put it here, and then you just lift a bit, cut here. Then you release this one here, tarik keluar. Are we exposing any suture material inside? Infected one? You see, how many of you have thought about that? We never think about it, right? That's why all these things are made here towards the end. Man. So that's why when they lift it up, they lift a little bit and then cut here. Once they cut, they can pull out this one. When they pull out this one, the whole non-infected part comes out, release out. There are only two purposes. Okay? Tension, infection. Clear? Is it a new perspective for you? That's very important. Okay, so we have been practicing, but we don't realize that. We do it, we don't realize. We don't do it as well. Okay? So if we don't have time, even if you have time, even if we remove the suture, if we put the knot at the wrong place, we'll end up introducing the infected skin downward into the body. You can't say a normal person may not exhibit any problems, but those who have got comorbidities like diabetes, hypertension, kidney disorder, a little bit of microorganism good enough to infect the whole thing and can cause cellulitis. Okay? Thank you. So with that, how many minutes? 60. Okay. So, is there any questions on suturing technique? Nothing? Okay. We take a break, 5 minutes. Just loosen up yourself. I know it's very hectic today. Bear with me for another 1 hour. After that, we are free to have our lunch and lepa. Okay. We can talk something else. Boleh, huh? Okay. Just 5 minutes break. Thank you. Okay, can we start? Sudah? Close the thing. Okay, so it's not fair for me to not to wear facial mask, but I don't have one. Okay, so so I'll just perform this. Okay, assume this is a model, not a real patient now. Okay. So sterile field is important, of course. The field has to be sterile. Once we have cleaned up that portion here, right? This is cleaning up. Okay. For example, the person who's doing it, basically we should not be touching anything else. Okay. What we do, sterile gloves, so if possible faster. Okay. Even if you don't have the cap, okay. And for your drink, not necessarily the beginning. But if you have it, you want to show performance. Then you're going to charge them more. Whatever is that, assuming this is the. So what I do normally, I can touch this one. Right? This is your corridor, you show stuff. Center first. Center. Whichever deal with. And then expand it outward. Expand it outward. Number one is push. Right? Here. Okay. The second prominent. I don't trust the first one. Again, I start with the center. Center. And then nicely apply. Sometimes I need to pour the povidone if it's very badly infected. Then go take it around. Step out as far as possible. As far as possible. But don't keep it here, this sterile area. Then, in order to prevent any problem with the skin, follow povidone application. Povidone is corrosive, skin corrosive. Okay, I take the Usol. Similar way, apply, center, spread out. Center, spread out. Dispose of. I'll take another one, preferably, one last one at least, and then take this, apply again, spread out as much as I can, as much feel that I want. Once I've done that, I take this one, this is the gauze, is okay. You can even take a dry, sterile ball, then nicely dry it up. Important thing is make sure that the field is very clean. Okay, no any sediments. Okay, see the clean wound, nicely, perfect, nice, perfect, clean. Okay, done. But all this thing can only be done after giving anesthesia. But the first initial thing up to here is perfect. You can do it first. Okay, then dispose of. Then you take the this is not sterile. Do you want to keep it here? Throw it off. You can have it now. Next, the area is good. Everything seems to be all right. What do you do? Take that drain. What they did, cover the area, the rest of the areas. All these areas are clean areas, right? So then you do the suturing. Now, what I'm going to explain now is the knot, suturing knot. So you have this material, this over here, needle. I'm not going to inject. I'm not going to show you anything else. Nothing else. So I'm going to use the same stuff here, the micro. Okay. So again, when we are going to handle like this with the finger, it's going to be dangerous for us. So we don't do that. Right? We take the other one. What is that? No. It's my nylon. Can I beat up nylon? Can we? Sorry. This was myself. See, I got you right again. Right or not? What about this? Not open. Is it right, doctor? It's yours, right, doctor?
That is okay.
Good. Okay. The mistake what is it? She is unsterile. She nicely opened everything, cannot touch. I'll tell you how to do it. Okay, get me another nylon which is not open. Got plenty of nylon there. So your hand is not that sterile, okay? Okay, so she is not that sterile, but she's also not wearing gloves. But yet we can do something about it. Doctor, please open up what she's going to do. Let's see, expert. You saw that? That's it. I don't care whether it's sterile or not. But my hand is sterile. I take it. Perfect. Then I use my needle holder to open it up. Done. I dispose. Done. I hold it here, open it up. Done. I take a simple bite, but make sure that the bite is taken out. I'm not touching anything, you see. Done. Then I take this forceps, hold it with the forceps. But the problem is the forceps is okay. So done right. You see, I can hold it like that or leave it. We have a better forceps anyway. It's okay, no problem. Click it like that. I'll use this one. What else? The other team cannot win now. You see, I'm holding it exactly here. Am I right or not? Done. Okay, done. Now, I need to change. Perfect. Any issues? No problem, right? Assessment all done earlier. Now I'm going to suture. Okay, suture. This will always be, this is a wound which cannot be sutured because this is the wound which you should not be touching. Why? There's a wound gapping, I'm going to touch it. Obviously, your wound will be bad. So that's why there are many wounds that are left here for you. But you went and chose the wrong wound. Okay, so assessment of the wound starts with how gaping it is. If it's gaping like this, you think I'm going to do it. I'd rather don't touch. I just leave it, let it go, grow first. Anyway, let us change the field now. So although we have done some cleaning. Cleaning is done, right? Okay. Now, this is okay. Fine. Again, if you're going to put the suture here in the center, you are not going to give a proper attention. Right? This is also gaping. So always start the center. How many of you start in the center? All start in the center. Good. You see, I'm holding the skin here, this one, taking a bite. Okay? I can do this as long as there's a bite. Alright? Or I can hold this with my finger, take a nice bite down, I don't have to go completely. I can even push it away, take it out like this. Betul? Then I take another bite. This is one way of handling tissue. As far as possible, try not to touch the thing with the finger, right? Okay, so you take another bite, done. But this is okay, fine. That's all right. Distance almost here. Take a bite, bring it up, tarik. All right. The knot is important here, right? Right? Perfect. Leave it. Have I touched the needle? No, don't touch. Dangerous. Because you know that HIV and all those things, we are prone to get them. But in the clinic, how we do? Touch everything. So the right way is this. 1, 2. Mode of 11. You might need third one. Okay, still all right. Bite. Take it. Done. Take seconds. Done. Third bite. Done. See, but under tension, right? You see that? Done. Now what do you do? Bring it to the side. Okay? Then take the scissor. Yes. Take the scissor. Bite. Right? So I don't go for multiple knot bouncing. One, tarik. Again, I do it. I don't have to waste my time. I should not be touching. I prefer this now. It's very important now. Sometimes, because it's not comfortable for us, we tend to have the inclination to go and take sometimes instruments are difficult. So, second, assuming that I'm good. You see, this is done. So, what is the distance here? I take a bite. This is approximate distance. Right? And I take, let's say, if I take another bite here, another bite. All approximate lah, okay? Boleh ya? Too far, right? Don't condemn, doctor say, doctor, not good lah. You're teaching wrongly, Right, done. Second one. Alright. Now, the suture which I told you is one part lah. This one. Sometimes what we do in the OT, we go for this knot. Have you practiced that knot? Anyone knows that? Yeah, okay, forgot. Give a big hand. So this is called hand knot, okay? But here we normally use it for intra-abdominal, extra-abdominal, whatever lah, okay? So how do we do? Dr. Bala, can you remember? Forgot, another applause. That means you say they are all instrument-based doctors lah, don't joke lah. You see, take this, hold it, go in, bring it inside. Take out this one, the basic stuff, go back. Alright, same thing. Dr. Alex, remember still? Can Forgotten you tak pakai lah. Then second one, this is for in the Ashini, all these things are very important. There are few techniques in this. One is like this, you take it, one finger technique. You see that? Second finger technique. See that? The other one is this technique. This way. Right? This is the surgical thing that we do in the hospital. Right? Can you all do it? Go into, remember, last, go in. First technique is two fingers going in, and then you lock it down here. Then take one finger, tie it. Okay. The other way around is this way, you see? Like this, same. Boleh. Then you can do. Can you see? Faster you can do. If you are good, faster. You can do very fast. That's why they want you to be fast means surgery, they call you fast. Hey, I want Dr. Bhavani to come in last. Like that. Okay? Can you all try? Again, last one. Hold this. Go in. Hit it here. Go up. Take the finger, the middle finger. Prod it, bring it. Slowly. Do it slowly. Can you? Okay. Now, after doing that, we have to clean the surface. Alright? Can I have some cleaning part? I've done all the work. What I do, I take U-Sol again. I take U-Sol. Right? I take U-Sol. I clean it nicely. Wow, that's it. Okay. Same way, go outward. Dispose. Take another one. Touch it. Same way outward. Nice. No bleeding, nothing. I'm happy with the wound. Perfect. Down. Throw it off. Done. What I do? There are two ways. Either I can put a gauze on top of it and make it up, or no bleeding, nothing. I take this beautiful. Where is that phone? Barang lah. Kalau malas, beli ini. Buka, bagi buka lah. I cannot open, right? Must right, throw it. But nurse lah, our nurses lah. Alright. Have you seen this, doctor? Not the head plaster, you know. You see the number, I always get confused. I bantai tanya, staff, tarik sini semua salah. So follow this order, huh? One, done. Then all this you can touch here. Two, done. Sorry. Then you can open this, take it out. All this thing dispose, huh? Dispose. Sharp, dispose in the sharp. Okay, that's my duty, not your duty. I caught you again, come here. Keep it down. That's not yours. Where is it? Scissors. Thank you. Okay. Somebody, all of you got it, right? Okay. Leave it. Okay. Now I can just take it out. Perfect, right? I just apply this. Apply nicely on top. Dan cantik. Buka ini dua, tiga. Nice, ditarik macam ni. You don't tarik, there's another way. Tarik carefully, ya. See, you're lifting up. So slowly you tarik dekat. Done. Dispose. Take out. This one sharp, smooth. Move. Sharp. Okay. Boleh, ya? Dispose. Cycle, simpan balik. Okay. Done. Careful with your finger and other things. Alright. Dispose. Dispose off. This one not utilized, boleh pakai balik now. Okay, that's all. And this one dispose. This is sharp. All the sharp we have to throw ourselves, not the nurse. Some nurses some people we don't like, I just take the needle. Go on. Okay, doctor, habis cukup. Right? Jangan style macam ni, ya. Semua salah. You injected, you have to dispose of. Boleh, ya? So this is done. Can keep it back. Someone? Any questions? No. Yeah. Okay. Good. Bhavani challenges me. Yes, Dr. Bhavani.
Like this kind of
Alright.
there's a special technique.
Okay. Alright. Now, very simple answer. Do you have any suture material?
Okay, so my question was in the corner wounds, right? So there's a special technique of suturing.
What is the best that we can do? What is the best that we can do?
Usually, what I do is I'll put one suture over here and one suture over here to the side.
It is your convenience. Okay, it's all our convenience. Okay, if I happen to do, you see the cosmetic outcome. If I suture like this, but I don't have to go here, because this is the fixed tensile skin. So what I have to do, I turn it out. Okay, I turn it like this. Okay, done. Then I take, because this particular thing, you can even release this at the bottom. You can just release it. Although sticking there too, you take a knife or whatever, just release a bit. Okay? So take tip to the tip like this. Okay, done. Okay, so once I've done that, Tarik, betul? Dilepas susah kan? So what do? Monofilament always like that kan? 3 kali. So that, masih lagi kacau lah dia. 4 kali kita tadi dia tengok. Boleh? Kalau tak boleh, apa kita buat? Panggil orang tekan. Tekan. Right, done? Done. So you got this thing, okay? Now cut it. Cut it. Perfect. Now this is medium. Start from here. Start from here. This is easy cosmetic. Right? If you happen to do this, anyway, it's all the same. But I want to secure. Let's say, as you say, I go in like this. If I happen to go in like this, okay, I take another bite, whichever way, doesn't matter. If I take another bite, like this, okay, I take a bite here. Okay? Thank you. Photo. And then I take second bite over here. Whichever way, doesn't matter. Second bite. Nice bite. Perfect one. Distance maintained. Nampak ni? Anak sudah rosak. Okay. Dah cantik. Now, doctor, semua peragam yang ngomong. Peragam tak ada betul lah mereka. Dia mesti gaduh sama dia. Sengaja dia doktor bilang. Okay, now. Okay, pegang. Terima kasih. Okay? 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 Now, I've done it right. Now you see what happens. I followed your technique. What happened? Gap is there. So now you're going to ask me to adjust the gap, right? I'm going to adjust. What happened, you see? Whatever adjustment I do here, the problem is this is already fixed. Then you want to bring it, it's going to be tough. So better fix the tip first. This tip for the mouth, fix it first. If you don't fix the tip, you go and catch this one, all this stuff. Any more questions? Go ahead. Yes, doctor. Raga wants mic and blast me. Okay. Yes, doctor.
If face laceration wound,
Okay.
maybe a cheek area or something,
Right.
would you prefer simple intra suture or subcuticular suture?
Fantastic. Dr. Bala, which one? I just pushed the question. Yeah.
Dr. Bala, mic
Yes. Simple intraocular suture or subcuticular suture? Okay. Big hand. Subcuticular. Yes, next. Next. What do you prefer? Wow, another one. Hantam. Dr. Bhavani.
Simple interrupted suture because I'm more confident with that.
Right. Excellent. Okay. Yeah, whatever. Okay, good. It's a very nice question. I have to sell you for the question. Which is easy for you? Is going underneath like a snake in the water, come out and tapato you, or better to see from top?
Actually, I had a case over the cheek area, and I don't know any other technique other than the intrap. So I did intrap, but I had a feeling it's a face, it's a cosmetic purpose. So
Right.
I just thought, I should know the subcuticular. At least I can do better for the patient. So I thought, okay, I need to know more about subcuticular.
Excellent.
But I later on came out to know subcuticular got some other complication.
Now you know purposely asking me, you see? All a pandai, you know. I want to trap me lah. Okay, listen. Subcuticular we use absorbable suture. Although the face is provided with lots of circulation, there's a high chance of healing, all those things, granuloma can form. Okay, this is not our own skin. The suture is different material. Okay, just imagine chromic catgut is worse, catgut is worse, vicryl is also same. Right, some of the real last time champions, wife and all those things, they have blebs all over face. This is granuloma. So I'd rather prefer to give interrupted. Therefore, if I find any complication, I take it out. If I see anything underneath me, I don't know what's happening. Oh, chante lah, beautiful outside, inside, pus, what are you going to do? Right? So always better to suture the face with simple interrupted suture. To minimize the scarring, use the smallest possible suture. You have 6O, you can put a microscope and suture. Alright? Another thing is in cosmetic surgery, what we do is different technique. All this. You see, we don't take bites which is distance. We take, this is cosmetic surgery. Huh? Where's the, I take this. We always go for cosmetic surgery like this. We go to the edge because the cosmetic surgery is in the teeth. So this is not even the one. Take it at the edge like that. Then take it edge. Smaller suture material. Okay? Edge to the edge. Thinnest material. Smallest needle. Boleh ya? Slowly we go in. Pegang doktor. Pegang. Cantik. Now you see. I just approximated the edges. You understand? So it's like that. Just cut them. Then when you remove the suture, what happens? The line? Thin, beautiful line. So in all microsurgery, cosmetic is all about the material thickness, the technique applied, and the instrument, the focusing part. That's why you see people have face lifting. They lift up here, but the cut is here. They have to lift up here, the cut is here, but they are not visible badly. Even they cut here, this one can be seen if you put. But you take some powder and apply, do you see that? Right, very fine, you can't, that's why all of them use. Louder, what they use? Simple. Any more questions? I saw one case recently, this area of the skin, here, okay, this particular, what do you call this? What eye is that? Eye bag, okay. They cut it like that, one shot, the second layer on top, remove all the tissues inside. You have to be careful, you have to burn something, and then brought it together, they put some cuticular sutures. I don't dare to do this. Even this surgery, when you do it here, you go up, lift up, combine. I'd rather do that. Instead of taking from here, go down and taking from here. That's a technique. So go for this minimally invasive. Don't go and show your expertise in this, because people please cannot destroy them, right? At least if you don't destroy lah. That's how it goes. Huh? Make sure you don't destroy lah. Make minimal. This is not about showing skill. This is about patient altogether. Okay. So with that, can you all start your practice to perform hand tying knot plus hand tying knot. Okay, hand tying knot. Letak balik, hand tying knot and tarik balik. Hand tying knot, right? And I will ask you later. You get feedback. Okay, boleh? Okay, please proceed. Okay, come. You can take one table here. Okay, so we are going to learn today the hand tying knot. Okay. Straight, yes, straight. Okay. Straight to go. Straight. That's always the practice, Dr. If you can, better lah. Okay. Okay. All right. Sure. Please proceed. Comfortable. Surgeon should not kneel down. Surgeon should stand. Okay? Surgeon should stand. I can understand. Some surgeon wants to be teacher. Okay. Okay, like betul. Slowly, learn. Hold this comfortably, something like you can hold this way or you can hold this way. I prefer this way. Then bring the fingers in. Bring it inside. Bring it inside. Put it on top. Okay, you see? Bring it inside. Bring it inside. Put it on top. Remember, hold this, bring it inside, put this on top. Take out the finger like this. Okay, you see? Bring it inside, put it on top. This middle finger, you bring it down and put it inside. Okay, then? Right? No, wait. Shadow holding salah. No, salah. This way. Yes. Put your two fingers there. Wait. Okay. That go down. No. This has to go on top here. Right. This one go inside. Take it out. Yeah. Block. Yes. Okay, good. Alright. Here. Okay. You see here? Short. Okay. Take out nicely. You see here? Simple way of holding it. Put two fingers. Two fingers here. Two fingers. Bring it down. Bring it down. Bring it down. Put it on top. Yeah. Then this one goes down. Put this on top. Remember. Bring it down. Put it on top. Only mobilize your middle finger. Like this. Like this. Okay. Hold with these two. No, wrong. This way. Put the two fingers. No, two fingers like this. Yes. Don't use three fingers. No, two fingers. This one out. Okay. Then bring it here on top. Okay. Then fold it. You are almost there. Okay. Two fingers. Two fingers. Go down. Bring this down. Go inside. Yes. That's what? Lepas ni. Yes. You got it. Got it. Almost. Belakang. Tarik. No, that side. Here. Yes. Put it. Do again. Do again. You get the pressure. Click. Okay, right. This is hand tying knot. How is it working? Doctor, got it? Very simple. This is just a good. Yes. Hold this like this. This one, two fingers here. Yes, and then put it on top. Hold it on top. And take this one, hold it. Okay. Sorry, doctor. Now. Now. You hold it. You hold it. Yes. On top. Yes. Yes. Okay. Yes. You can use any finger. Don't worry. You can use any finger you want, but the method is same. Oh, that one cannot. You have to only use middle finger. That's the one. Yes. Middle finger. What you do? Take out your blood. Take out your blood. Take out your blood. Okay. No. Okay. Very simple. Don't forget about all this. Okay, leave it. This one go up or down. Take this one, keep it this way. Using the then carry it. Okay? Hold it nice. Yes. Simple. Like this. Perfect. Okay? Yes. Correct. Okay? This okay. Like meditation. Itu normal. Iதை மட்டும் புரியுங்க. Correct sir. You always remember. Hello. Hi. June. அதுக்கு ஹை ஜூன் வேற ஒரு இவ்வளவுதான். இதான். சரியா? Yes? This is Bye-bye. Bring it.
Yes.
You can bring all three also, no problem. But your functioning should be one or two fingers. So I put 2 fingers. Or I put 3 fingers. No problem, 3 fingers.
Yes.
If I 3 fingers, I can use this. Or you can use this also. You understand? So I put this one easy for me now. See? இதை வந்து இப்போ பிடிச்சிருக்கல இதை புது போட்ட கை வந்து இன்னும் போய் போட்டு இது வந்து இப்படி இருக்கு இப்படிதான் அப்படிதான் வரணும் அதுக்கப்புறம் வந்து இதை வந்து நம்ம மொபைலைஸ் பண்ணி இங்கே பிடிச்சிட்டு இருக்கோம் இதை போட்டால் இதுக்கு கீழே வரும் கீழே வந்துட்டு பாஞ்சிட்டு yes ready betul all are perfect use this finger இல்ல இப்படி இப்படி போகணும் உள்ள போகணும் ஜஸ்ட் இது மட்டும் சலா ஓகே யோகா தேவை இதை மட்டும் சுத்தம் இதெல்லாம் சுத்தம்லாம் தேவைப்படா வேண்டாம் இது மட்டும் உள்ள போயிட்டு yes only playing the finger correct this alone have to come in yes don't do anything yes what you did is what I'm doing right perfect excellent right okay very good all right fantastic okay what about you yeah you got it yes future surgeon how is it Dr. Bala your junior okay sometimes there are various methods there, you can like that, okay, you can do a lot of things, cut this one. Necessary, right? See the various methods are like this, some people go for all 3 fingers, take it out, some people go for 2 fingers, take it out, some people go for only 1 finger, see here, 1 finger, finish, some people go like this, you see once you become better, for example, once you become better, they say, put your finger, give us one, you say, one finger, you see, 1 finger. You can do it 1 finger, 2 finger, 3 fingers. Yeah. Okay, happy. That very good meditation. Okay, what about this side? Yes. Okay.
Okay,
Dr. Bhavani did once after how many hours? Okay, good. You want the time now?
Yeah, like this.
That's right. So once this is done, I will have that work surgery, cutting case, his hand is very easy. Surgical department.
yes.
Oh, this is just still right.
Okay, one group completed. I believe one group. Hello? One group just completed their work on hand knot. Okay? And second group also feel very confident, sitting comfortably. Okay? Great. The Bala is tired, of course, I know, like me. And the third group is still struggling to capture what they want. Right? Dr. Bhavani wants to explore today the hand knot technique. Oh, Harshini now. Harshini, is it okay for one day? Go ahead. Done, don't worry. We'll stay here and we'll also ask Dr. Timothy to be here until night. Okay. Until Dr. Harshini learns. The most important is not you being successful in tying the knot. You just have to understand the concept. There is a knot like this. This knot is usually not meant for skin application. Not for skin, forget about it. This is meant for abdominal, intra-abdominal, organ, all these things. Right? You will be so important that when you apply such knots, the surgeon doesn't want you to use any instrument because there are organs inside, like liver. Right? Do you think you want to use knots? I mean, using instrument and break it? No. So you have to assist the surgeon and you put the knot slowly, very slowly. Right? I had a mentor, my senior consultant in urology. She was number one in the country. Alex also worked under her. Right? Urology. She hates me to the core and she loves me to the core. Right? The best part is she wants me to go every day. I did mention that to Dr. Every day I have to assist. If anybody, I can, no, I want that floor. Okay, but there's a reason for that. So go there, get bombarded throughout the day. But she told me that, no. You actually got a good hand, you know. You can become a surgeon, you know. Right? So that lady was there, you know, to really motivate. And she's high level of precision. Alex knows how she does the work. Alex knows. So she's good, really good. Although she's been quite indifferent, I feel like that. But fantastic, the work is excellent. Like the work, what you see, the bathing up. Clean feel. That's why she doesn't prefer others. She wants to do with someone who knows the things. Right? You just, by the time, see, normally people would hold that whole here. With me, I'll start my incision, abdominal incision. Alex, have you done the abdominal incision, alright? I do it. By the time I go early, I don't wait. I train patient, everything done. I cut first straight. Open, and go to the third day. Say, why are you so fast? You waited for me? No, it's okay. That's it. Fine. She wants me to do it. Fantastic. The kind of feeling. So then going up to the deep fascia, peritoneal layer. Beyond that, don't touch that. That one beyond that, she'll ask you to suture. But you suture that portion, suture this portion. Okay, so fine. So nice exposure. Surgery is fantastic. I assisted the surgery for about 14 hours. Crap, man, the next day I could not go for work. Emergency time. That was an emergency situation. Okay? From here, bottom up to here, the next day was the jam. I could leave. Right? Under crystal ball. Okay, never mind. Now go back to this. How did you find about the hand tying knots? Right? Okay. Doctor, did you manage to learn? Hard, but she's going to learn. We are going to catch her. Who's going to monitor? Dr. Ashwini? Dr. Alex. Okay? Don't ask him to bombard you or anything. Don't worry. Tell I will see food. Dr. Kiran asked me to learn. You will listen. Okay? What about you, doctor? Okay, Dr. Bhavani needs more practice. Dr. Bala. Dr. Bala, expert, no problem. Coming up, surgeon. Done. Relax sampai cerita. Excellent. Give a big hand. Now, here. Hands on tying and aftercare. Not tying technique. You have learned. Then, testing the knot security. You have to test it. Right? Which you have not done right. So you don't get points for that. Okay? Then you have dressing technique. Learn the dressing technique very well. Then patient advice suture removal. What advice do you give patient? Take your mind. You've done same thing like cut here, your own lah. You've done the suture. What is the next advice you give to patient? Come take the mic. Yeah, proceed. Proceed, doctor. You have done the suturing, about 40 sutures for the hand. What do you want to say? After suture, post suture. Doctor, that's something. Copy others now. Okay.
Okay. Sensitive lah.
Get back to you. Come. Right.
After the suture,
I'm your patient. I came in, doctor sutured me, everything is done. Doctor, how do I take care? Doctor, what am I supposed to do? I don't have to wait 10 days. Somebody said tak boleh mandi leh.
not open my dressing.
What's that?
Not touch my dressing.
Oh, jangan kacau ah. Doktor Maya jangan cakap apa macam tu.
Yeah, because sometimes some patients they don't want the bandage to be there, so they will open up. So just concerned about the infection.
Okay.
So we will always advise not to open it, and then when we open, we have to assess back the wound whether got any pus, anything, or any infections like any erythematous or not. So usually not to open it, and then I will ask to.
Okay, thank you. Pass it to Dr. Alex. Dr. Alex, what advice will you give?
So once we already bandaged up, then the patient not to soak or wet the.
Okay, not to soak and wet it. Yeah.
So just remain, don't try to open up the bandage by yourself.
Right.
Always not for daily dressing.
Daily dressing. This doctor Maya jahat tau. Jahit 2 jahitan dia mangkat daily dressing charge saya RM30-40 ni. For company very dirty. Acceptable. It's okay. MK is getting money, it's fine. Okay, hopefully you make more money anyway. Next, pass it over to Indan. Thank you, Alex. Okay.
The same thing. Just make sure do not get it damp and wet.
Okay.
And don't take it out and come for dressing.
Okay, come for dressing. The question is, when you go to review the patient, Dr. Balas,
Some questions are really after dressing. Okay, right? Especially when we go to toilets or taking water.
Wow, yes. There you go. This is seniority. Doctor, salute. All of you salute. Yeah. Stand up and salute. Stand up and salute. No, salute. Doctor, I also get it. Stand up and salute. That's it.
So then go to
Seniority.
You take the antibiotic every day.
Excellent.
I see you back day after tomorrow. You.
Okay, fine. Acceptable. Be infected, doctor.
Then every
tomorrow. Okay, good. Excellent. Next. Dr. Bhawan, you will challenge the seniority now. Yes, Dr. Bhawan.
Yeah, because maintain the hygiene.
Maintain hygiene. Same thing, right? Okay,
Yeah.
good.
Maintain the hygiene, and then so depending on the wound, infected come early to review, that means the next day. If not, we can give POD to review the wound, and then come for STO. So depending on the location, so if it's space or years, anything facial, maybe up to 7 to 10 days, we can remove the suture. Or if it's like lean with high muscle, high skin tension, maybe we can give up to 14 days.
Excellent. Good. Perfect. So now the question is, I have injury on the face. When are you going to remove my suture? Again, answer.
So I'll give 7 to 10 days depending on the patient's healing capacity as
Right.
well.
But she's very smart. Healing capacity. The board will come to a number. Healing is 100%. No, Dr. Bala?
I think if we palm or sole, I go for 10 days. The rest 5 to 7 days.
Okay.
Early.
Dr. Indah, what about you? Indah. Tak tahu lah.
Whatever Dr. Bala.
Whatever Dr. Bala said, good. What about you? 7 to 10 days on the face. What about Dr. Prakash? Give a big hand for Praga. Praga won. Okay, phase is always 5 to 10 days, don't go beyond that. Why? Very, very highly supplied by circulation blood. So it heals faster, unlike the other cases. And another thing, if you manage to remove by 7 days, there's no chance of granuloma formation. 7 to 10 days is a big goal. Phase target less than 7 days. Okay? Right. Now, scalp. Itu sudah jahit lah. Bila saya mau datang jahit, buka jahit lah. Okay, Alex. 10 to 14 days. Shoot fast. Whatever Dr. Wala says. Dr. Wala is. Yeah. 7 to 10 days. Tadi macamnya orang ni.
10 days.
10 days. This one you can always say wait for the healing part lah. That's it. Generally, scalp is thicker. We go for at least 14 to about 16 days. If it heals better, yes, you can put about 12 days. So 12 to 16 days, that's it. Right? Next. Tangan. How many days? Huh? Okay, 7 to 10 days, acceptable. Good. Palm. Palm and feet. Yes, it can go even up to 20 days. Betul kan? Okay? Anything else? Any other parts? Now, my mucosa, oral. How many of you sutured oral mucosa? Inside the mouth. Benar tak? Have you done it inside the lip? They are very fast healing. I've done many lah. Lip koyak, jahit juga. Atas koyak, jahit juga. Right? The worst thing is you have to be very careful with the ear pinna. Remember this. Why? What's the reason for cauliflower ear?
Cartilage.
Cartilage. What's wrong with cartilage? Cartilage okay, what? Yes, avascular area, the chondroid bone, we call it chondroid bone. Cartilage is avascular actually. Right? So anything hits it, there's no blood supply, it crumbles and becomes into, assume the shape of cauliflower. So how do you handle this? Minimal tissue handling, maximal antibiotic, not oral. Alright? You may have to go for 10 to 14, 15 to 20 days oral with broad spectrum antibiotic, Curam, Flagyl, Bangin, and IV antibiotic, ceftriaxone, 1000 milligrams, 5 to 7 days or 5 to 10 days. You have to be very careful of that. This part is very, very dangerous. Close monitoring. Most of the Koya Pina, another thing is suturing technique in Pina is very important. You cannot take a bite on the condyle, the bone, the cartilage. Maybe that will be left for some other session. How many of you want to come for some other session? Next session. Oh Allah, not bad. Wow, not bad. So that thing I'll tell you later. Okay, good. So this next time I'm not going to talk lah. You guys are going to talk. If forever I'll talk. Right, good. So that is one part. Coming to other things, patient advice, suture removal, the technique for removal. I told you already. You all are experts now. Hey, jangan buat macam ini. Jangan angkat ini. Macam ini saja. All of you understood well? Next one. Now you see, suturing complication, infection is what we learned. Wound adhesion, it can just open up, if it's under tight here, adhesion can open up. Suture reaction and scarring. This is where we don't want things to happen. So how do you avoid that problem? Suture reaction and scarring. What is the worst thing that can happen to a person after suturing? Hypertrophic scar. Sama? Keloid. Where does keloid take place? Which areas? Bony prominence. Right? So these are the places where keloid comes in. How do you avoid keloid? Question comes with keloid. How do you avoid that? You have to tell them first. Doctor, Ms. So Dr. Praga, Ms. Praga, you have got a big keloid here. If I do a suturing, it's going to be a problem. When the suture, your cut is very small, so I'm trying to avoid keloid. Right? So in that case, what I'll do, I'll just put a plaster. Approximate. Praga, don't worry, I'll give a subcuticular suture. That is where you use subcuticular suture. Alright? The reaction is at the level of skin. The reaction is minimal at the level of hypodermis area. So just go just below the skin level. dermis, hypodermis, hypodermis, epidermis, hypodermis. So go down and then use the plaster, clapping. Or put 1 or 2 suture in between plasters. That's it. Even if it develops, you can later give sheet protection. So there's a technique there. Okay? That one we'll talk about next time. Boleh ya? Okay, next. Repeating. Next is complication and best practices. What we learned. So we have learned what we know that we have to prevent the suturing complication, right? Suturing related complication. Post procedure, wound care, we have to tell them, right? Take good nutrition, right? Avoid strenuous exercise. Sleep well. Take 7 to 8 hours of sleep, right? Take egg every day, 2 or 3 eggs. Provide more protein for you, right? Do not touch it, right? Don't do dressing on yourself if you have Usol. That one disturbs my pocket money, right? Okay, so all these things, don't tell them lah, the smart way lah, right? Okay, so pocket money important, doctors are suffering, right? So all of you know that. Okay, so that's what important. Explain that. So remember, your PPE, your glove, your head, this thing, whatever instrument you have, placing all these things, expensive. So now what's the price for suture? What's the price that you're going to go for suture after this? 70. Doctor got the thing right. So if you are trained, you can charge more. If you're not trained, 15. You understand what's the importance of training? Confidently you can do that. Confidently you come down. Okay, good. Next. Determine timing is important. Okay, now you see the wound suturing, quite well done. They applied whatever povidone or maybe Usol. This is wrong because when you apply povidone, it can be corrosive on the skin. Try to wipe it nicely with a better background. Flaming is okay. I had patient flaming infection, reactive to flaming. Apply flaming, became so soggy. Then I stopped flaming, Usol soggy. I said, what the hell is that? I knew this is a reaction. What I did after that, what should I do? Don't do something. Normal sign, finish. 3 days, dried up. Next flight. Next time. This is what I'll be waiting for. Okay, now stand up, please. All of you look tired. Alright, thank you. Stand up. Just be relaxed. Loosen up your body. Loosen up your body. Tarik nafas. Sakit belakang kan? Okay? Tarik nafas. Close your eyes lah. Okay, you can rotate the weight because your shoulder must be aching. Rotate the weight, opposite. Excellent. It's not exercise anyway. Kau tak sakit tak? Betul-betul sakit kan? Sekarang duduk. Sebab saya mau oksigen. Jawab soalan. Okay, good. Who wants to start first? Who wants to start? Very easy question lah. I won't be begging, right? Tak apa, kita bagi Arsini. Minum air dong. Okay. Arsini, Dr. Arsini, right? Put the question first. First question. Tak banyak. Tak ada apa lah ni. Okay. Can I read for you or you can read? You want to read? Okay, you read and you answer. I'll give them.
The question is, what is the most important principle when approximating the wound agents during suturing?
A. Tight closure to prevent bleeding. B. Loose approximation to allow drainage. Accurate approximation without excessive tension. Rapid closure to reduce procedural time. Deep price to ensure strength.
C.
Wah, janganlah jangan ni. You won. Happy birthday. Next, doctor. Next slide.
Which situation best indicates the use of interrupted suture?
Read up.
Okay, A. Long, clean surgical incision. B. Low tension cosmetic wound. C. Irregular or contaminated wound. D. Linear wound with minimal bleeding. E. Closure required a rapid technique. B. Tension.
How many of you say B?
Body.
Or D? What is your answer? Tengok kena juga. What is it? Saya tengok semua kena tak semestinya kena lah kan? What is it, Dr. Alex? Go back to the basic principle. Yes. C. A. Want to change your answer?
D.
D. Actually, want to challenge your senior? Challenge her. What's the answer? D. She follow lah. Right. See here, situation has indicated interrupted suture. One suture, two suture, three suture, or interrupted. Long, clean surgical incision. Surgical incision.
Continuous.
Yes. Low tension cosmetic wound.
No.
Cosmetic.
Absorb.
Low tension cosmetic, just approximation. Interrupted also. But here you can go for subcuticular as well. That's what I'm trying to say. Irregular or contaminated wound. The answer. But after you clean up everything, you have to have interruption. If you don't have interruption in between, right, you have to get interrupted. Your answer is right. Oh, doctor, contaminated, no future now. Fair enough. But irregular and contaminated, you clean up first. Okay, what they are trying to say, clean up first. And then you apply the suture. Alright? Our brother one. Udah. You should answer more doctor. Alright, next. Dr. Bala. Mention lah yung sebelum makan nak pakai kan.
Okay, suture material is most appropriate for skin erosion.
Vicryl is absorbable suture, brother. Oh. Anybody else want to try? Got it. Dr. Bala sedikit salah pun boleh hantam. Dia kasih try orang lain. Good. Nylon. Right? Next slide. Next one. Right.
What is the main purpose of ensuring non-security and during suturing?
Amen.
So, to prevent wound rehesion.
Yeah, you got it. Big hand, please. Susah buat challenge sama dia lah. Okay, next. Now, proceed.
What is the safest method to handle the use suture needle after completing the procedure? C.
What you all did just now? All pantai nombor 3 lah, pass directly to the assistant by hand. Good. Jahat lah orang. Right? Okay, good. So yeah, got it done. Next. Right.
How should the needle holder ideally grasp ingredient?
Yes. Alright. It's a good point. Correct. Okay, big hand please. Or anywhere along the needle lah. Anybody want to put a stick there? No, huh? Next. Thank you. Thank you so much for all your 4 hours of attendance. Not easy. Thank you so much, all the doctors. I really be grateful for you to present the morning, Sunday, and taken your time. I hope all of us learn together something today. Alright? And I'm hoping for you to be seen in future to be another trainer. Right? I know all of you can perform fantastic. Right? It's a matter of coming out, being bold and talk.